Live streaming is starting.
Hello.
Hello.
Yes. Hi.
Hi, Nadeem.
Hi, Mrinmoy. How are you?
I'm good. Can you hear me? Hi.
I can hear you. You are absolutely loud and clear.
Perfect.
Minmoy, I am
That's perfectly visible.
Mamata di কেমন আছেন? কেমন
ভালো
আছেন
আছি,
Mamata di?
ভালো আছি। হ্যাঁ,
হ্যাঁ,
Very good.
ভালো আছি তো, very good।
এই আছি মোটামুটি। আজ ভালোই
আচ্ছা।
আছি।
ভালোই।
ভাই সব ক্লিয়ারলি শোনা যাচ্ছে, দেখা যাচ্ছে।
মৃন্ময়, তোমার প্রেজেন্টেশনটা কত টাইম লাগবে? Coming to business straight away.
45 minutes plus, I guess.
That plus is which plus? 2 plus, 3 plus, 1 plus, half of plus minus? Hey, তোমার mute হয়ে গেছে. Just unmute yourself, please.
Yeah.
Yeah.
Okay. So, yeah.
So 45 minutes, is it?
45 to 50 minutes, hopefully. I mean, I intend not to go beyond that. I mean, I've got about 100 slides, but they will, the slides which I present, most of the slides, they go very quickly.
Yeah.
So
just let me introduce you to Dr. Sejuti Dasgupta. She's an associate professor in Calcutta Medical College Pathology. She's the master of the ceremony, and she is the one who's going to coordinate everything. So
Good evening,
Sejuti,
sir.
good evening, Sejuti.
এই আমি যে কাউকে দেখতে পাচ্ছি না।
ম্যাডাম, আমরা আপনাকে দেখতে পাচ্ছি।
আপনাকে সবাই দেখতে পাচ্ছি।
কিন্তু আমি মিনময়কে দেখতে পেলাম না, পাকলু।
আপনি ওই ভিউটা দেখুন, আপনার ভিউ পয়েন্টটা, ভিউটাতে আপনি একবার ভিউতে চলে যান।
ভিউতে দেখলাম তো, কই নেই তো।
এটা গ্যালারি ভিউ নাকি আছে? দেখুন, আপনি ল্যাপটপে করছেন না?
হ্যাঁ, কই পাচ্ছি না তো।
Good evening, doctor. Sorry to interrupt you here. Doctor, sorry to interrupt you here.
Go ahead.
Yeah.
দেখা
Dr.
যাচ্ছে না।
Niranjan here. I'm a technical department here. Doctor.
Yes, please, Niranjan.
Doctor, this is Niranjan from technical department. I would like to give small introductions here.
Right.
মিনময়, I have seen you.
Good.
Niranjan, go ahead.
I can see you too.
Sir,
Yeah,
I would like to
we
tell
have
that
4 more minutes.
means the voice will be lots of interruptions. Okay, so I will request everybody to speak one at a time because it is going on live, and make sure that everybody is going on phone on the mute, and everybody should make background voice to be avoided, and make sure that any external noises heard in the conference. Thank you, sir.
Thank you so much. That was like a headmaster.
Yeah, over to you, Deepak.
So, sir, we'll sharp start by 5 o'clock. Sanjiti ma'am, I'll send you the questions in WhatsApp. Okay.
Okay. Thank you. Thank you.
So, ma'am, we'll start sharp by 5 o'clock.
Yes, of course. Yes. So we start in 3 minutes. Sir, you introduced me to Mrinmoy sir and didn't get an opportunity. Sir, Mrinmoy sir, I've heard all your lectures on Neelam Pact, and it's wonderful. Sir, it's an honor to actually speak to you like this. Thank you so much, sir. Is Mrinmoy sir here?
No, I think he has left. And
Okay, sir. Doesn't matter.
Soon.
All right. So all his lectures were so nice on your platform.
Yeah, there are many more to come. And he himself is coming to.
Meanwhile, you are muted.
Yep. I don't know why my button keeps on going to the mute button. The cursor, I mean. Anyway, I hope you can all hear me now.
Yes, sir. Yes.
Perfect. Yes.
So
yes.
I was.
Thank you for your compliments, Sanjuti. What I wanted to say is that the credit of the entire thing for those lectures that I've been taking goes mostly to Nadeem, right? So I'm just a part of his team. Happy to be
I was
there.
so grateful to all of you for getting this to us. I mean, it's wonderful to have all these lectures available. We can hear them anytime. I keep on saying telling Nadeem sir that it's so wonderful. Thank you so much, sir.
Yeah.
Both of you,
pleasure.
both of you.
My pleasure, my
Fabulous.
pleasure.
We are happy to see you, Minmoy. You are my
Mamata di,
younger brother, Mamata di.
absolutely.
Ah.
Absolutely. Good to see you.
Yes,
Good to
me
see you.
also.
Yes.
Anyway,
And
we are countdowning. We have just 30 seconds left. So
Yeah.
we start, right?
Yes, sir.
Jayashree.
Yes, sir. We can start now.
Yes.
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 এই আমার মিনময়কে ছাড়া কাউকে দেখতে পাচ্ছি না।
Fine, ma'am.
So
We'll
we are
start.
starting now.
Yeah.
Good evening and a very warm welcome to Professor Shubir Kumar Datta Memorial CME and 14th Annual State Cytology Conference 2021, organized by West Bengal Cytology Society. We present to you a 2-day spanning program packed with numerous captivating and engaging sessions. This evening, we come together on this virtual platform to celebrate our passion for learning with Professor Shubir Kumar Datta Memorial CME. The theme for today's CME is indeed very interesting. Of all the things we've been forced to swallow with the advent of the COVID-19 pandemic, the West Bengal Cytology Society believes that you will not complain about this one. So, with great vigor and enthusiasm, let's swallow the salivary gland. I would like to invite Dr. Indranil Chakraborty, Honorary Secretary, West Bengal Cytology Society, and Organizing Secretary, Professor Shubir Kumar Datta Memorial CME 2021, to please say a few words. Indranil, sir, please.
Thanks a lot, Dr. Shejiti. Good afternoon, friends and colleagues. I extend my warm welcome to all the registered delegates on behalf of our team of West Bengal Cytology Society. We have tried to put together a very interesting mix of topics pertaining to cytology practice. So today on day one, as Dr. Shejiti has already mentioned, we will have our pre-conference CME on salivary glands. We have dedicated this CME to our legendary teacher and pathologist, Professor Dr. Shubir Kumar Datta sir, who has left us for his heavenly abode. So first of all, I would request all to kindly maintain 1 minute of silence as a tribute to his noble soul. Thank you so much. May sir rest in peace and bless us all from above. Without much ado, I will hand over the proceedings to our Honorable President, Professor Mamata Guha Mollik Sinha Madam. Madam, please.
Madam, please unmute yourself.
Madam, you need to unmute here.
Okay. Good evening, everybody. Are you hearing me?
Yes, madam.
Good evening, everybody. I feel proud to welcome all the delegates and international and national speakers to Professor Dr. Shubir Kumar Datta Memorial CME and 14th Annual State Cytology Conference 2021 on virtual platform. We are missing our beloved sir in all respects. This is the first time we are organizing CME and conference without sir. But we believe that sir is always with us. The organizing committee and MIE conference are working hard for last 2 to 3 months. I have confidence that their missions will be successful. Our PGTs of different institutes will present award papers, e-posters, and field papers also tomorrow. I hope all of you will enjoy the whole program very much. All the best. Thanks. Now I am requesting Dr. Shayed Nadim to speak about our beloved sir. Dr. Nadim, please.
Thank you so much, madam. It's a privilege to be asked to speak about Sir at the first Professor Subir Kumar Datta Memorial CME organized by WBCS. Professor Dr. Subir Kumar Datta, an eminent pathologist of India, a teacher of teachers, was born on the 24th November 1935 in a doctor's family. His father was Dr. Salendranath Datta and granduncle Dr. Kartik Chandra Bose of the famous Bose lab in Amir Street. His mother was from a Zamindar family at Chinsura. She was daughter of Rai Sahab Nobukishore Bose. Dr. Subir Kumar Datta passed matriculation from the prestigious Hindu school in 1951, MBBS from Medical College, Kolkata, DCP from School of Tropical Medicine, and MD Path and Bacteriology from University College of Medicine, Kolkata. Initially, he joined government service as medical teacher and served there from 1963 to 1989. Later, he was a professor of pathology, University College of Medicine, where he guided hundreds of students for post-graduation and graduation. In truest sense, he was a great motivator, friend, philosopher, and guide. He was Dean Faculty of Medicine, Calcutta University for 3 terms. He had more than 75 publications in national and international journals. Till the last breath, he was the director of his own laboratory, the famous Scientific Clinical Research Laboratory, which is one of the most renowned labs in West Bengal, situated at his residence, which is 2 Ramachandra Das Road. He left us for heavenly abode on the 14th May 2021 due to COVID. He is survived by his wife, Srimati Rupa Sri Datta, daughter Nandini Basu, and grandson, Dr. Soumitra Basu. Practically, it is impossible to depict here all the posts, chairs he had held in academics, socio-medical activities, administration, and different associations. Just to highlight a few of them, he was a past national president of IAPM 2004, vice president of the West Bengal Medical Council, medical secretary of Asiatic Society, member of the Senate and Syndicate, University of Kolkata, examiner and paper setter for MD, PhD, DNB, DCP, MBBS, DMLT, BMLT courses, chairman Finance Committee, University of Health Sciences, member Dental Council of India, and the list goes on and on. He has received Eminent Teacher Award in 2003 from Calcutta University. Government of West Bengal awarded him the Bishishto Chikitsa Samman in 2019. Lifetime Achievement Award from Medical College, Kolkata and IMA, Bengal chapter, and Lifetime Achievement Award from Shambad Pratidin in 2019. He was a very kind and affectionate to all. We will cherish his memories throughout our lives. Albert Einstein said, the value of a man should be seen in what he gives and not in what he is able to receive. This CME by WBCS dedicated to him is a very small gesture of gratitude to a towering personality, Professor Subir Kumar Datta. Sir, we love you and we shall miss you. Thank you so much. To serve with love.
Thank you, Nadeem sir, Mamata ma'am, and Indranil sir. we directly move on to the first session of the evening. The topic for this session is cytomorphological approach to salivary gland lesions. We are delighted to have a renowned cytopathologist to speak on this important topic, Dr. Mrinmoy Kumar Malik. He is currently the consultant cytopathologist in the Department of Laboratory Medicine, Mubarak Al Kabir Hospital, Kuwait. He had done his MD in pathology from PGI Chandigarh. He has more than 22 years of experience in practicing cytopathology. His areas of interest are cytopathology of pancreas, GI, thyroid, soft tissues, and the role of HPV in cervical cancer. He has several publications in indexed journals. It is an absolute honor to have you here, sir, this evening. I would now like to request Dr. Malik to kindly begin his presentation. Sir, please.
Sir, you are muted. Kindly unmute yourself.
Okay.
So,
one moment. Can you see my screen now? See my screen now?
no, sir.
All right. I'm sorry. Okay, so you should be able to see me now.
We can see you, sir, but not the presentation.
I see.
Just below, you can click on the share screen. Your PPT is open.
Yeah, my PPT is open. One moment. Right, so I'm sharing my screen now.
Yes, sir.
Okay.
Yes, it's there, sir.
Yeah.
Now make it full screen, sir.
One moment, please. How about now?
Yeah, it's okay, sir. It's
all
okay.
right.
It's visible.
Okay.
It's visible, sir.
Perfect. Right. So first of all, thank you for this extremely generous introduction. And let me begin by thanking the organizers of this CME for this invitation. I'm extremely happy to be in the midst of such distinguished speakers and panelists. And it's of course a great honor to be speaking in a forum which is dedicated to one of the true giants of pathology in our country, Professor Shubir Kumar Datto. So, as you can see, we have a very daunting challenge in front of us. This is the WHO classification of salivary gland tumors with numerous entities. And in order to get about it, in order to provide you with an approach, let me begin with this photograph, which I had taken in 2017, looking down into the famous Haleakala crater in Maui. So usually we just start from the top of the crater and then you go down to the bottom of the crater. It is a one-day trek. And people can, and the trekkers, they use different approaches, some well-known approaches, and sometimes you can change your approach. And this is exactly what I intend to do in trying to approach the salivary gland tumors through fine needle aspiration cytology. But before our approach, we should try and revise and remember some of the essential facts related to salivary gland lesions. Most of them are extremely basic. The fact that carotids account for most of the salivary gland tumors, followed by the submandibular, sublingual, and other minor salivary glands. There are some tumors which tend to be more bilateral than the others. The ratio between benign and malignant tumors is roughly 3:1. Important thing to remember that about 15 to 20% of parotid tumors are malignant. However, this goes up to almost 45% when you go to tumors of the submandibular and other minor salivary glands. FNAC has established itself into a very, very significant role as far as salivary gland pathology is concerned. It has a sensitivity and specificity to a rather high, but when it comes to the accuracy in subtyping a neoplasm, it can vary between 40 to 90%. And there are a number of determinants of accuracy, like number of passes, whether the lesion is solid, cystic, location, and a few other factors. We also should know that certain lesions have a preference for certain sites. For example, polymorphous adenocarcinomas tend to exclusively involve minor salivary gland tumors. It is extremely important to take a proper and thorough clinical history because we can get some very good leads from that. And imaging, very, very crucial. In fact, most of the recommendations in most of the standardized literature and other bodies, they say that we have to image using CT, MRI, and at least an ultrasound before we go about putting in the needle. However, the practice and guidelines may be different at different places, depending on the availability of stuff. It's important to maintain a multidisciplinary approach and also try and use a standardized reporting protocol, the Milan system, about which you're going to hear later in the evening. Now, the salivary gland is located, in fact, the glands are located at a very busy traffic intersection, which means that there are not only salivary gland tumors per se, but tumors arising from lymph nodes, the soft tissue, the bone, all of them come in the differential diagnosis. And therefore, it is absolutely crucial that we have an idea from where the lesion is starting. And that's why it's very, very important to know the imaging findings. Now, my approach to salivary gland tumors is as follows. It starts with a very humble differentiation of lesions into two halves: inflammatory cell conspicuous, inflammatory cells inconspicuous. Now, going to the side of the inflammatory cell inconspicuous, this is what we do. We divide the lesion into cystic and solid. That's what I tend to do, right? Now, amongst the solid lesions, this is where the fun starts really. I divide it into two different groups. Lesions where the myoepithelium-derived matrix is conspicuous, and lesions where the myoepithelium-derived matrix is inconspicuous. Now, under the myoepithelium-derived matrix, which are conspicuous, there are a number of entities we are going to come to. Among the myoepithelium-derived matrix inconspicuous group, I divide it into three different blocks. Those with myoepithelium-derived cells matrix inconspicuous with cells with a high NC ratio. We tend to call them basaloid cells, maybe a bit of a misnomer, but that's what I do. Remember, cells with a high NC ratio, then cells with a low nucleocytoplasmic ratio, and spindle cells, right? Amongst the cells with a low NCR, I tend to group lesions into the predominant cell type: oncocytic, acinar serous, squamous, clear, mucinous, and cells which do not fit into any of these particular previous cell types. Now, crossing over to the other side of the bridge with lesions which are inflammatory cell conspicuous, divide them into cystic and solid, and then divide the solid lesion based on the predominant inflammatory cell component. So let's begin with the first one. We start in the middle, right? We start with the myoepithelium-derived matrix conspicuous group. So the lesions which you have in this particular group, you may be able to add a few here and there, but this is more or less the most important ones. So pleomorphic adenomas with atypia, pleomorphic adenoma X carcinomas, basal cell neoplasms comprising of basal cell adenoma and basal cell adenocarcinomas. It is pretty impossible to differentiate between these two because we do not see the infiltration and other facts which are necessary to diagnose a basal cell adenocarcinoma unless you see some high-grade features. Myopitheliomas, epithelial myoepithelial carcinomas, adenoid cystic carcinomas, and polymorphous adenocarcinomas. These are the ones which we start with. Now, this is what I like to do. I'm going to provide you with a collage of photographs of lesions which you just saw. And I'll just give you a moment, just a few moments to just kind of make a diagnosis in your mind that what could be from where before I show you the next slide. So the first one is from a pleomorphic adenoma. The next is a myopithelioma. This is a basal cell adenoma showing some kind of matrix. This looks pretty spectacular, the adenoid cystic carcinomas. This is an epithelial, myoepithelial carcinomas. And this one is a polymorphous adenocarcinoma. You can see a bit of the mucin, right? Sorry, the bit of the matrix. I'm sorry about that. Apologies. Right. So one of the features which we consider as very important is to compare the appearance of the matrix. So we try to see if the matrix that is in, we see is fibrillary in nature, like here and here. This is the PAP and this is the MGG. You can see the wavy fibrillary kind of nature to the matrix, or it is a kind of a chunky hyaline kind of matrix. So why do we do that? Because matrix can be a kind of a decider, but we shouldn't hedge too much on them because there are a lot of overlap. So when you talk about fibrillary matrix, pleomorphic adenomas, basal cell neoplasms, myoepithelial neoplasms, EPMs come under this. In hyaline matrix, we have got adenoid cystic carcinomas, basal cell neoplasms, myoepithelial neoplasm, epithelial myoepithelial carcinomas, polymorphous adenocarcinomas. Some of them can show both fibrillary as well as the hyaline kind of matrix. So it is better not to put too much into this, except for one important fact, and that is usually you do not come across hyaline matrix in pleomorphic adenoma, but I have actually seen certain cases, which are known cases, which turned out to be pleomorphic adenoma, even on histopathology, where there could be small bits of areas of so-called hyaline matrix. It can depend on the staining quality and other features. Right, so this are some pics of pleomorphic adenoma. You see the fibrillary matrix. This is a kind of a higher power. This is a low power view. You see this plasmacytoid cell over here, and this one you have already seen, the fibrillary matrix, right? Myoepitheliomas and pleomorphic adenomas, they have a lot of overlap. In fact, some people consider them to be like the same tumor, right? But look at this particular matrix. It has kind of a globular quality, like you see in case of adenoid cystic carcinoma. So it could be tricky. This here is a kind of a dense hyaline matrix in myoepithelioma. Here you can see the streaks of matrix going through the cells, and this is a higher magnification view of a myoepithelioma. Basal cell neoplasms, I'm not using the word basal cell adenoma or adenocarcinoma. Basal cell neoplasms have this very dense hyaline kind of a matrix. Basaloid cells, as you can see over here, very tightly clustered. Okay, and you can see this hyaline matrix adhering to this clusters and sheets and aggregates of cells. Right. Now, this is adenoid cystic carcinoma. They look pretty spectacular, and they do so because of the presence of these kind of globular hyaline matrix, right? But I can tell you that these kind of globular hyaline matrix may be seen in a number of other tumors. So you have to be very careful before just jumping into adenoid cystic carcinoma whenever you see them. One thing which I find very helpful is that in most of the circumstances, when you do a PAP, the matrix in adenoid cystic carcinoma, they do not pick up the stain too well. But again, something like you see here in the low power, here in the high power, but you cannot use that always, because sometimes this is a case of an adenoid cystic carcinoma, but look at the matrix, it's pretty thick over here. So you have to be very careful about drawing conclusions based on individual features. Now, this one is an extremely tricky tumor, epithelial myoepithelial carcinomas. Now, these tumors are often mistaken as pleomorphic adenoma. So this is one of those cautionary tales, right? So what you have are large sheets of cells. Some of them have kind of a papillary configuration. They have a lot of bare nuclei, a lot of individually scattered cells, okay, which are present in the background. You will find some component of some amount of clearing. Look at the clear cells over here, but you can't find this clear cell even in pleomorphic adenoma. The nuclear pleomorphism is not that much. What people tend to talk about is this kind of a lamellar concretion kind of a matrix that you see over, not so clear over here. And if you do a P63, well, you will see the myoepithelial cells on the outside and the other cells are on the inside, which do not take up the P63. And that's fair enough. I mean, this is a tumor which can be very, very difficult. So I decided to dedicate one slide to this one, which I'm going to do only in some of the entities. The epithelial myoepithelial customers, remember, they're extremely tricky customers. They have a wide age range with a mean of around 64 years. They are difficult to pick on cytology. They are often missed, and they're often mistaken as pleomorphic adenomas, just mentioned. So what do you look out for? So you are looking at a tumor which looks like a pleomorphic adenoma. That is your first gut diagnosis, but you see 3D balls, and then you see some pseudopapillary aggregates. You see numerous bare nuclei, and you start seeing a lot of clear cells. So whenever you see a pleomorphic adenoma, you see a lot of clear cells, well, it should ring some bell. It should put on the warning bells inside. So with exhibiting the so-called dark inside, dark outside clear pattern, and what I have shown you, the concentrically laminated proteinaceous secretion. YSC on cell block may pick up the outer myepithelial cells surrounding the inner epithelial cells. So this is another one, a polymorphous adenocarcinoma with matrix production. Sometimes they do produce matrix. So this is not from our case. This is one article that was published in Cancer Cytopathology way back in 1999. And luckily, they did it in color because most of the journals at those times, you had black and white reproduction. So this is pretty good. And it tells you that why this group of tumors come in the differential diagnosis. The good thing is that these tumors are mostly tumors in the minor salivary gland. However, most of the tumors that we have talked about before can also occur in the minor salivary gland. So it could be a problem. No. This is the time also to talk about carcinoma ex pleomorphic adenoma. So you are going to find, what you find is, you will find some areas where there are these areas which just look like pleomorphic adenoma, and other areas you are going to find this high-grade tumor. However, in most, you will be very, very lucky to find both of them in the same case, because most of the time, the high-grade carcinoma areas, which is most often the salivary duct carcinoma, overgrows the pleomorphic adenoma, and on FNAC, you may not be able to find it. So we have to keep that in mind. So carcinoma pleomorphic adenoma. So you have to think about it when you have a long-standing tumor, which nobody ever aspirated, nobody ever worked up, and suddenly there is a recent rapid growth. It may even show facial nerve palsy and skin involvement. Most of the carcinomas, ex-pleomorphic adenomas, are salivary duct carcinomas. And the pleomorphic adenoma component may be rarely reflected, and these are positive for PLAG1. Now, that is important. PLAG1 is positive in pleomorphic. It is one of the markers of pleomorphic adenoma. So when you do a carcinoma ex-pleomorphic adenoma, you see a high-grade tumor, you do PLAG1, it turns out to be positive. It is a kind of a sign that this is a high-grade tumor, a salivary duct carcinoma, whatever, or epithelial myepithelial carcinoma, which has risen out of a pleomorphic adenoma. So that's very important. So do a PLAG1. So next, the next group of lesions are lesions with minimal or no matrix and high NC ratio. So what are those lesions here? So amount of matrix minimal. So they could be cellular pleomorphic adenomas where you don't see the matrix. They can become very, very difficult. Basaloid adenomas, adenocarcinomas, adenoid cystic carcinoma, the solid variant, which is histopathologically defined by a particular content more than 30%. Polymorphous adenocarcinomas can have minimal matrix. And of course, do not forget a very bad one, small cell carcinoma, round cells, tightly clustered, and a benign lesion, chronic silentinitis. And I'm going to show you why. So this once again, we are back to the collage of slides where you have 6 of them. And just you can try and make up your mind what each one of them might be before I show you what they actually are. So that one, your left is a pleomorphic adenoma, the cellular variant. This is a basal cell neoplasm. This is an adenoid cystic carcinoma solid variant. The cells here tend to be a little bit larger. They can show some mitosis. They might even start showing a little bit of nucleoli. This is a palatal tumor, a polymorphous adenocarcinoma. Look how similar they look. This one is a small cell cancer. Well, with experience, you might be able to pick this one up with the apoptotic cell with a kind of a necrotic background, small cell carcinoma. But the last one is very tricky. Thankfully, these lesions, the chronic silentinitis, are not very cellular, but when the gland is affected by chronic silentinitis and do an FNA, you might find these very tight clusters of kind of atrophic ductal cells, which might look like basaloid cells. So you have to remember that. Okay, so polymorphous adenocarcinoma, some views of polymorphous adenocarcinoma, the cellular type with less amount of matrix. as you can see over here, forming a kind of a cribriform pattern, very tight clusters here, right? So you get the drift as far that why this group of lesion has been put here. We have to run through the slides because I'm sure I'm not being able to do justice to each and every one of the lesions, but since it's an approach of all the salivary tumors within a span of time, so I have to rush through. I'm sorry about that. Each one of them is a seminar in itself. And finally, we come to this particular table, which is an extremely important table. Now, I have used this table to deal with the two groups of lesions that I have spoken about, matrix forming lesions and non-matrix forming lesions with high nucleocytoplasmic ratio. I've done so because the tumors in the differential diagnosis are almost the same. So this is the panel which I like, right? So P63 and P40, they will stain all of them: pleomorphic adenoma, basal cell neoplasm, adenoid cystic carcinoma, myoepithelial neoplasm, that is epithelium and myoepithelial carcinomas, epithelial myoepithelial carcinomas, and polymorphous adenocarcinomas, right? The important thing is that polymorphous adenocarcinomas are P40 negative. So this is the wisdom of you putting a P40 right in this particular panel, right? Smooth muscle acting, once again, is negative over here. Now, LEF1 is a good marker for basal cell neoplasm. However, some pleomorphic adenomas can be LEF1 positive. Next, PLAG1. PLAG1 is positive in pleomorphic adenomas, an extremely reliable marker. However, we have to remember some myoepitheliomas and myoepithelial carcinomas and polymorphous adenocarcinoma, I think around 25 to 30% of polymorphous adenocarcinoma, if I'm not mistaken, can be PLAG1 positive. So if you're using PLAG1 to differentiate between pleomorphic adenoma and polymorphous adenocarcinoma, be careful. It's better to take into account the P40 staining. HMGA2, they stain a lesser number of pleomorphic adenomas, so they are less sensitive, but they are more specific. But once again, it is known that myoepithelial neoplasms can be HMGA2 positive. MIB is a really good marker. They pick up adenoid cystic carcinomas. Most of the others are negative for MIG. Almost all the others are negative for MIG. CD117 is kind of a much touted marker in this particular group of lesions, but not really very helpful. It was initially thought that it only stains adenoid cystic carcinoma, but a large number of pleomorphic, we don't find it useful in our practice. And basal cell neoplasms are CD117 positive, and so are polymorphous adenocarcinomas. So moving on to the next group of lesion, and that is low matrix or no matrix. So we are right here, myoepithelium derived matrix inconspicuous, non-basaloid cells with low nucleocytoplasmic ratio, and you have got all the different subgroups which I'm going to go one after the other. The first one is the low nucleocytoplasmic ratio acinar cell serous type. What are the DDs? Normal salivary acini, sialadenosis. I'm sorry about the mistake here. The spelling sialadenosis, acinic cell carcinoma of the serous acinar cell type, because there are different kinds of acinic cell carcinomas. Right. So this on top is sialadenosis, and this is acinic cell carcinoma. In sialadenosis, they tend to keep the architecture. You see the salivary acinar architecture, they tend to retain some of the fat, and they'll also have the salivary ductal cells in between. Whereas in acinic cell carcinomas, it is the similar kind of cells, which possibly a higher nucleocytoplasmic ratio. I find the background to be very useful. It's kind of a granular kind of material in the background. We see a lot more bare nuclei. Okay, but the most important thing which I use to differentiate is the fact that in acinar cell carcinomas, we do not see this resemblance to the normal salivary acini that we see in sialadenosis or in other normal salivary aspects. So this is normal salivary acini. As you saw over here, you can see the ducts. This is a low MAC of an MGG. So sialadenosis, a few words. It's actually a diagnosis which you have to make in combination with a lot of other knowledge. It's a persistent non-neoplastic or non-inflammatory enlargement of salivary gland. It is mostly parotid and could be often be bilateral. Usually there is an underlying disease, like patient can be an alcoholic, cirrhotic, diabetic, hypothyroid. So look for these things when you are going to diagnose sialadenosis. You're thinking of HIV, pregnancy, and certain drugs. People on antihypertensives tend to show they're more frequently affected by others than others with sialadenosis. So imaging correlation is necessary. If you do not find the proper imaging correlate, you call it non-diagnostic if there is a definite mass or lesion. So you see a salivary gland in which there is a definite lesion and you are seeing just benign salivary acinar cells, you do not call it sialadenosis. You are going to call it non-diagnosis because it means that your needle has not hit the lesion. Actinic cell carcinoma, some of the views of actinic cell carcinoma, as you see over here, this looks almost like normal salivary acini. This is a higher magnification views, right? And it can show PS positive, diastase resistant granules, the zymogen granules, right? So a few words about actinic cell carcinomas. They're the second most common malignancy. They have a slight female preponderance, a mean age of 50. They're usually asymptomatic, slow-growing tumors, but they can undergo a high-grade transformation. When you see pain or fixation, that means that it most likely has gone into transformed to a high-grade. There are various cellular types. We have seen only the serous acinar type. We will talk about the vacuolated and clear cell type, and there are others like intercalated, ductal, and non-specific glandular. The architectural types could be of various patterns, as you see in histopathology: solid follicular microcystic papillary cystic. On special stain, you have PS positive diastase resistant granules. The important immunohistochemistry, very, very important. DOG1 is very useful. SOX10, and a very recently introduced NR4A3, which at least currently considered to be a very, very good marker. But you know the story with these markers. With years as they progress, you will see people coming out with papers where they will show that there are other tumors which are positive. But so far, NR4A3 appears to be quite promising. Next, from acinar to oncocytic lesions. The differential diagnoses are right over here. Oncocytosis, Warthin tumor, oncocytoma. This is a very interesting lesion. Oncocytic, mucoepidermoid carcinomas, pleomorphic adenomas, and myopitheliomas can show oncocytic change. Actinic cell carcinomas can show oncocytic change. Salivary duct carcinomas, can show oncocytic. All of them are going to come into their DD, and not to forget the Mets. Right? So once again, a collage of 6 pictures showing oncocytic lesions from the previous page. And in the next page, so first one I think was extremely easy because of the content of inflammatory cells, Warthin's tumor. I know this can also go to the other side, that is inflammatory cells, conspicuous lesions. So Warthin tumors kinds of bridges this gap. We'll talk about it later. Oncocytomas, it's oncocytoid mucoepidermoid carcinoma. It looks almost like an epidermoid cells. This is oncocytoid cells. Sometimes you can find in pleomorphic adenomas. This is an actinic cell carcinoma with oncocytes, and this is a salivary duct carcinoma with oncocytic change, which can occur quite often, actually, at least focally. Right. This is just like the easiest of all diagnoses as far as salivary gland pathology is concerned. Warthin's tumor, we see this multiple layer of oncocytic cells in the core of lymphocytes. The background sometimes can look notoriously mucinous, but most often it has got a dirty granular background, and you can have a lot of degenerated cells, some kind of parakeratotive cells, and some cells which seem as if they contain mucin, which is very interesting because of of a particular phenomenon which we are going to discuss a little bit later. Now, a few words about the oncocytic variant of mucoepidermoid carcinoma. Many of the mucoepidermoid carcinomas, rather, will have a population of oncocytic cells, but only when the number of cells is more than 50%, we use the word oncocytic variant of mucoepidermoid carcinomas. And this one, I've just taken the picture from an article published by Antonio et al. In 2015. And there is another article, a cytohistologic correlation of mucoepidermoid carcinoma, emphasizing the rare oncocytic variant. So out of the 23 cases which they found, oncocytes were seen in 22% of the cases on FNA. So this is almost a quarter of the cases of mucoepidermoid carcinoma, you will find oncocytes. On histopathology, it can go up to 43%, right? But out of 10 of their cases met the criteria of oncocytic mucoepidermoid carcinoma based on the greater than 50% cutoff, and 3 of them were mistakenly called Warthin's tumor. So this is definitely a kind of a pitfall we should keep in mind. Right. So what is a useful panel for oncocytic tumors? So I put one group as Warthin or oncocytoma. They share a similar kind of panels, which they're positive and negative for. Mucoepidermoid carcinoma, actinic cell carcinoma, salivary duct carcinoma, the main ones. So as you can see over here, P40 does a pretty good job in differentiating mucoepidermoid carcinomas from oncocytomas. Positive in mucoepidermoid carcinomas, whereas it is negative in oncocytomas. DOG1 is the star marker for actinic cell carcinomas, but a particular percentage, I don't exactly remember the count of mucoepidermoid carcinomas, can show DOG1 positivity. And of course, for salivary duct carcinomas, androgen receptor. So androgen receptor positivity in salivary duct carcinomas helps them to differentiate them from other tumors. So if you use this panel, you get a fair amount of idea of what this tumor actually is. Next to the clear cell vacuolated cell tumors, this is the list: myepithelioma, myoepithelial carcinoma, epithelial myoepithelial carcinomas. You could have oncocytomas with clear cells. Of course we can. Actinic cell carcinomas with clear cells, mucoepidermoid carcinomas and clear cells. We'll talk a little bit about secretory carcinomas. Clear cell carcinomas in general, I'm talking about the clear cell carcinomas of the palate, okay, which can, of course, they're by name, they're defined as clear cell carcinomas. You only see it here. I do not have a slide to show you any FNA of a clear cell carcinoma, the so-called hyalinizing clear cell carcinomas of the palate. I have not even come across any FNA reports in literature, but if somebody has it, do share it with me somehow. And Mets with clear cells, right? So these are another collage of clear cell tumor. I think you have seen this one a little while ago. This one should be easy, right? That one is a very interesting entity, right? This gentleman had a tumor somewhere else, so I guess you know what it is, right? Here you go. So this is an epithelial myoepithelial carcinoma. It's clear cells, and you can see the inner layer of ductal cells, which is smaller, and the outer clear cells. This is an oncocytoma, turned out to be an oncocytoma. This is a grandmother of a colleague of mine who had this lesion, and it was a histopathology was done in that case, right? Actinic cell carcinoma with clear cells. This is a secretory carcinoma. This is a mucoepidermoid carcinoma, the clear cell component, and this one is a renal cell carcinoma. All of these tumors are later on proven with the help of either histopathology or immunohistochemistry. So you have to trust me on that. I really don't have the time to show you those because that is going to eat up a lot of time. Okay, so secretory carcinomas, very, very important. I think there is going to be a lot of talk about secretory carcinoma in the next lecture. But on FNA, these are the things that we see. We see this kind of large papilliform clusters and some amount of discohesive cells associated with them. Now, this is very interesting. Look at this matrix. Doesn't it remind you of the fibrillary matrix that we found in pleomorphic adenoma and that group of lesions? So, although it is in this particular group, I have seen secretory carcinomas tend to show something which resembles or is actually matrix. I have seen some in mucoepidermoid carcinomas also. So it is not that that group will never ever show a matrix. The cells tend to have an opened up chromatin, prominent nucleoli, and the kind of a watery kind of a material in the background, okay? And a very frail kind of cytoplasm. This is another view. They are positive, very important. They're positive for mammoglobin and positive for S100, right? So secretory carcinomas have a mean age of approximately 50. They're slow growing tumors, but like actinic cell carcinomas, they can undergo high grade transformation. Many of them were originally called actinic cell carcinomas, but later on they were reclassified based on their immunohistochemical features as well as the molecular pathological finding. So they show cellular tumor, very variably cohesive aggregate sheets, papillae. There are many individually scattered cells, a lot of strip nuclei. But what is definitely going to attract your attention if you are looking out for them are vacuolations of variable sizes, including some panched out vacuole. I find this very helpful, watery vacuolated background. They have an opened up chromatin, prominent nucleoli with smooth outlines. They are positive for mammoglobin and S100, positive for GATA3 too. So be very careful if you are, one of the differential is that it is coming from the breast, and that has to be, differentiation can only be done based on the clinical history. MUC4, SOX10 can be positive. So this is one of the tumors like actinic cell carcinoma which can be SOX10 positive. They're negative for DOG1, negative for NR4A3, which should be helpful in differentiating from actinic cell. P63, P40, ER, PR, and androgen receptors are negative, differentiating from salivary duct carcinomas and differentiating from ER/PR positive breast carcinomas. There were typical molecular cytopathological changes, which I have shown over here, associated with the ETP6, NTRK3 gene rearrangement. This I find is a useful panel for clear cell tumors. Let's look at it. So as far as P63 and P40 are concerned, it helps to differentiate between myepithelial neoplasms and oncocytoma. As you were saying in the previous panel, they are negative, right? Secretory carcinomas can be P40 positive, whereas mucoepidermoid carcinomas are P63 positive. And they're actually, I think there is a mistake over here. They're also possibly positive for P40. I'll get back to that later on. S100 positive in myepithelial neoplasms and secretory carcinomas, right? DOG1 positive in actinic cell carcinomas and mucoepidermoid carcinomas can be DOG1 positive. Mammoglobin is very useful because they're positive in secretory carcinomas. The next, the low NC ratio with mucin containing cells, not too many in this particular group. Mucoepidermoid carcinoma, you'll have mucin containing cells, but along with it, you're going to have other cells. Some Warthin's tumors can have mucin containing cells, and there are salivary duct carcinomas with mucin containing cells. Mucoepidermoid carcinoma is the most common malignancy in adults as well as in children, right? Females tend to be more often affected than males. Okay, the major salivary glands are the ones which are affected along with the minor salivary glands. So most often the parotid followed by the submandibular. Now the histopathological grading, according to most systems, so this is an important issue, is three-tiered: low, intermediate, and high. However, some of the grading parameters used in histopathology, like circumscription, lymphovascular, and perineal infection, cannot be assessed on cytology. But there are certain grading parameters which can be assessed on cytology. This is the relative amount of tumor and mucin, mitosis, necrosis, and pleomorphism. A two-tiered grading system is, however, possible on cytology. It may be a treatment decider because low and intermediate grade, they go for complete excision, whereas the higher grade go for surgery along with along with radical dissection of lymph nodes and adjuvant therapy. Immunohistochemistry, they are positive for CK56, P63, P40, CK7, MUC1, 124, and 5. And they are negative for S100, SOX10, mammoglobin. Some may be positive, by the way, GATA3 and androgen receptors, which is very, very useful in the certain circumstances. And of course, a very well-known MAML2 fusion gene. I have only one slide related to the molecular cytopathology of salivary gland tumors. You will see that over there. Right. This is the appearance of a mucoepidermoid carcinoma low grade. The amount of mucin is abundant. Okay, the cells do not show any significant amount of pleomorphism. There is a lot of these cells that you are seeing over here. This is more of a low grade. This is some of the cells that look like epidermoid cells, and you can see some amount of vacuolations over here. Whereas over here, this is the mucoepidermoid carcinoma high grade, showing much more pleomorphic cells, much more nuclear membrane irregularity, a greater degree of hyperchromasia. So these are some representative images. Once again, A lot many slides I would have loved to show you, but I'm sorry I do not have the time for that. But that's okay. Right. Next, squamous cell lesions. Squamous cell carcinomas, epidermoid cells or mucoepidermoid carcinomas. Atypical squamous cells can occur in Warthin, and of course, necrotizing silometaplasia. I'm not seeing too many of these. In squamous cell carcinomas, one has to be very, very careful. This is a diagnostic pitfall because most of the squamous cell carcinomas in the salivary gland are metastatic squamous cell carcinomas, right? And in many cases, what you see are large number of enucleated squams. And they may be so overwhelming that if we do not screen it properly, and sometimes the malignant looking cells like these can go undetected. So whenever you see a lot of enucleated squams, we have to be very, very careful, take the history very carefully, because these cases are mostly metastatic squamous cell carcinoma. Sometimes the diagnosis is far more obvious. And this is it's a metastatic squamous cell carcinoma. I think it came from the esophagus, if I remember correctly. Okay, so this is a mucoepidermoid carcinoma with epidermoid cells, right? So sometimes the epidermoid cells do show high-grade features, like you see at the cell over here. This is not my case. I've just picked it up from the net, from an article published by Archana Shetty et al. It is a necrotizing silometaplasia of a hard palate, a rare entity, a dilemma on cytology conferred. So just look at this. If you come across one of these, this can be easily mistaken as a mucoepidermoid carcinoma. Right. Low NC ratio neoplastic cells not otherwise specified. What if it doesn't fall into any of the previous groups? So oncocytic, clear, squamous, mucinous, vacuolated, what do you do? So these are the ones in this group. Adenocarcinomas, NOS, when we are unable to say what it is. Actinic cell carcinomas, salivary duct carcinomas, large cell neuroendocrine carcinomas, basal cell adenocarcinomas, myoepithelial carcinomas, and not to forget METs, right? They can come everywhere. Right, so this is another panel. Let's see if we can pick up some of the lesions. None of them are really showing any of the differentiation that we talked about. Shall we just go to the next one? Right, so here we have an adenocarcinoma NOS where we couldn't go beyond this particular diagnosis. Actinic cell cancer. This is a metastatic breast carcinoma, if you believe it. This one is a salivary duct carcinoma. This is a mucoepidermoid carcinoma. Sometimes the cells may not fall into any specific type of cell which we really associate with mucoepidermoid carcinomas. But most of the times when you look around the slide, you will find the other helpful cells, but these cells can be present. And this is a myopithelioma, which can show this, polygonal cells, and sometimes it may be a problem to come to a good kind of proper diagnosis, and it can be very confusing. I can assure you about that, right? Especially the ones which look plasmacytoid, and some of those features, some very oval to round polygonal cells can look pretty nasty. And then we are going into the realms of the very rare kind of tumor called myoepithelial carcinomas, which I have not shown in any of the subsequent slides. Anyway, so let's talk about salivary duct carcinomas. As you can see over here, these tumors are really nasty looking tumors. So whenever you see a very ugly looking tumor, one of your differential is a salivary duct carcinoma. You do an androgen receptor, it turns out to be positive, and many of them are actually positive for HER2. So this is the HER2 staining, and the mean age is about 68 years, about 10% of salivary gland tumors, most of them occur in the parotid. Very interesting. Out of every 5 salivary duct carcinomas, 2 of them, that is almost 40%, are carcinomas arising on pleomorphic adenomas. There are a number of variants, rhabdoid, sarcomatoid, basaloid. This one is very interesting. Mucin-rich variant, as a result of which the DD will include mucoepidermoid carcinomas. They're positive for androgen receptors, positive for GATA3. Okay, so be careful not to call them breast. So this could be a problem. It can be positive for GCDFP. About half of them are positive for prostate-specific antigen. So you have to use other markers of prostatic CAs like NKX, to differentiate. They are negative for P63, CK56, and DOG1. Okay, it is important to PLGA1 because that indicates that it is arising out of a pleomorphic adenoma, on top of a pleomorphic adenoma, I mean, and high-grade transformations can occur also in actinic cell carcinomas and secretory carcinomas. This is a rather useful panel for ugly-looking, so-called ugly-looking carcinoma. This we are going to see, the neuroendocrine we'll see a little bit later. So P63, P40 will be positive in mucoepidermoid CA. This P40 actually, sorry for the mistake. Then we can use androgen receptors, which are positive in salivary duct carcinoma, negative in others. Always do a neuroendocrine marker because of what I'm going to show you a little bit later on. Adenocarcinomas, NOS, they can account for a significant number of cases, but I use it after I've ruled out other entities. So it's mostly a diagnosis of exclusion. So they are CK7 positive, 20 negative. They will be negative for P63, P40, S100, DOG1, androgen receptors. So all the other entities are ruled out. Negative for mammoglobin, negative for S100, and also do a neuroendocrine marker, negative for neuroendocrine marker. And this is why very rare large cell neuroendocrine carcinoma with salivary glands can occur. They can also metastasize to the salivary gland. They have extremely poor prognosis. So run a neuroendocrine marker and you have the diagnosis there. But it's very, very rare. And they are negative for TTF1 unless and until it is a met from the lung. Okay, right. At this point, just a quick look at some mets which we have seen in the salivary gland. This is from a breast carcinoma. You have to trust me on the immuno and the clinical profile. This is what we found was a prostatic carcinoma which metastasized to the salivary gland. Remember what I told you, and that is salivary duct carcinomas can be positive for PSA, right? This is a renal cell carcinoma metastasizing to salivary, and this, of course, is always there in every differential diagnosis, a melanoma metastasizing to the, so you can see the pigment over here, right? So the next one we are going to deal with is spindle cell lesions. So the spindle cell lesions are myoepithelioma, spindle cell type, schwannoma, nodular fasciitis, carcinosarcoma. I could think of these. I'm sure you can think of some more. Right, so this is a spindle cell myoepithelium. Look at the stroma, positive for CK, S100, P63. So a spindle cell myoepithelioma. This one is very interesting. This is, we can actually see it in the salivary gland. Nodular fasciitis. See how closely this nodular fasciitis stroma resembles the fibrillary matrix of pleomorphic adenoma. They can really show this so-called tissue culture fibroblast, some quite pleomorphic cells, this very plump, chunky fibroblast. So this could be a diagnostic problem. We see nodular fasciitis maybe once in a while. This is another tumor, soft tissue tumor can occur in the salivary gland, a schwannoma. This is a carcinosarcoma of the salivary gland. This is a cytokeratin, which turned out to be positive, a real ugly looking tumor, okay, having a very sarcomatoid kind of a look. Always when you have a sarcomatoid tumor, right in anywhere else, you should always run a cytokeratin, okay, along with other markers. Now, I don't have the time to go into the details of that. Now, next, the cystic lesions, the non-neoplastic cysts, these are the list. These are the lists of neoplastic cysts, Warthin's tumor right on the top. You can have cystic changes in pleomorphic adenoma. Of course, very important mucoepidermoid carcinomas, actinic cell carcinomas, secretory carcinomas. This is from a mucous retention cyst. This is a cystic mucoepidermoid carcinoma. This is a cystic adenoma. All of these are our cases. But if you have something like this, and I'm sure you will hear a lot about this in the Milan talk, it is always right to put the possibility of a low-grade mucoepidermoid carcinoma, the proper nomenclature. Just don't write mucous retention cyst, even if you are not saying anything else. It's very vital. Right. The grading of salivary gland carcinoma is just one particular slide on this. These tumors are by definition low-grade. These tumors are by definition high-grade, salivary duct, small cell, large cell, neuroendocrine, lymphoepithelial, and there are certain tumors which can be of multiple grades. I've already spoken about the grading of mucoepidermoid carcinomas. Adenoid cystic carcinomas can also be graded, not really recommended, and so can be myoepithelial carcinomas. Not recommended, I mean on cytology, and actually there are some of articles coming up that really do not recommend exactly grading, except mentioning the amount of solid component in the lesion as far as adenoid cystic carcinomas are concerned. This is a table showing the molecular cytopathology of salivary gland tumors. Some of the important ones for pleomorphic adenoma, PLAG 1 rearrangement, okay, right? And it's important because even in salivary duct carcinomas arising out of pleomorphic adenoma, you can see that adenoid cystic carcinomas, MIB rearrangement, but seen about 50% of ADCCs, secretory carcinomas, and show ETV6 gene rearrangement, okay? And mucoepidermal carcinoma, the very well-known mammal 2 rearrangement. But important thing is that this rearrangement is found in around 75% of low-grade MECs, but comes down to around 45% in high-grade MECs. And there are reports of Wilms tumor with mammal 2 translocation, but they are most likely low-grade MECs, which look like Wilms tumor. Right. Finally, we go to the other side, inflammatory cell conspicuous lesions. Lesions with conspicuous inflammatory cell component are divided into solid and cystic. So you have got lymphoid cell rich, neutrophil rich, granulomatous. And on the other side, the cystic lesion, we have these entities. We'll just rush through them, except one particular specific lesion. This is a reactive hyperplasia of intrasalivary lymph node. You can see a very polymorphous population of the cells, and you can see the salivary acini. This one is a chronic sialadenitis. It should not be here because usually they do not show too many inflammatory cells, but they can show certain changes in the in the ductal epithelium, as a result of which it can sometimes be very confusing, right? And we can get into areas of atypia and other associated issues, which you will hear about, I guess, in the Milan talk, that how chronic sialadenitis can be a problem at times. Right. This is a lymphoepithelial lesion. We'll see some more later on. This one is a diffuse large B-cell lymphoma, a very monotonous population of very large atypical looking cells. All they turned out to be positive for the B-cell marker. It was a B-cell lymphoma. This one is an acute sialadenitis showing amylase crystals. This is a case of a granulomatous sialadenitis in the case of sarcoidosis. Here is a case of a lymphoid tissue proliferation in association with actinic cell carcinoma known as tumor-associated lymphocyte proliferations or TALFs. Of course, Warthin's tumor has to come in on this side of the bridge because it shows a large number of inflammatory cells, mostly lymphocytes, as you all know. This is another lesion you have to be very careful about, lymphoepithelial carcinoma, one of the high-grade carcinomas which we talked about. We have these abnormal epithelial cells, malignant epithelial cells mixed with lymphocytes. But the key challenge is the non-Hodgkin's lymphoma salivary glands, which account for 1.7 to 6% of salivary gland neoplasms. Carotid is involved with around 70%. Extranodal marginal zone lymphomas are the most common, followed by DLBCL and follicular lymphomas. About 20% are associated with Sjogren's, which leads to a 44 times rise in the 5-year cumulative risk. So a pre-existing chronic disease and indolent course hampers the diagnosis. So a patient has Sjogren's, which is a chronic disease, the course is indolent. So when the ENM-ZL starts on that, it's very difficult to pick up. ENM-ZL can, of course, transform to high-grade lymphomas. Imaging, it is unifocal in around 35% of the cases, multifocal in approximately 65% of the cases. And this can provide clues which may be further refined with CT and MRI, but not easy, as they say, in a background of Sjogren's. So in the background of Sjogren's, even with CT and MRI, it is not very easy. Now, these are three different pictures I put. Now, this to the left is a reactive lymph node. You see a wonderfully diverse population of lymphoid cells. So this is a reactive lymph node. Okay, I'll be pretty okay calling this a reactive lymph. This one is a diffuse large B-cell lymphoma, a monotonous population of large cells. Here is a problem. This is actually polymorphous, but if you see along with this, there are small lymphocytes, and the other population of cells are this kind of intermediate size cell. Whenever I see this in a salivary gland tumor, even if it is polymorphous, I start getting worried. And some of the other pictures of the so-called extranodal marginal zone lymphomas involving the salivary glands are here. So here you see a polymorphous population, but there seems to be a kind of you see a pretty predominant number of these intermediate sized cells. See over here, and this is a slightly larger cell. So when I see something like this, if you could just keep the picture in your mind, I start getting worried, right? And they show cellular smears with polymorphous populations. So it is one of those lymphomas with polymorphous population of cell with the predominance of intermediate sized lymphoid cells and a smaller admixture of small lymphocytes. Difficult to pick up unless you have it at the back of your mind. It can show a variable admixture of monocytoid B cells, plasma cells, lymphoplasmacytic cells, and immunoblast in the background. Unfortunately, it can show tingible body macrophages. So you can't rely on this to differentiate from reactive condition. It sometimes show lymphoepithelial aggregates, so it doesn't really help. CD20 positive, 5 negative, 23 negative, CD10 negative, Ki67 is low. So this panel is very useful. And often we use flow cytometry. Okay, so here is a tumor which show the kappa restriction. It is positive for CD20, and some CD38 positive cells are also present, and a few CD43 positive cells, I guess. But you can pick up the kappa light chain restriction or even the lambda light chain restriction, depending on the case, on flow cytometry, and it helps. And many times I've come across come to learn about situations where a patient gets repeated FNACs done. Okay, you're calling reactive lymph node, do a flow, and the diagnosis is going to pop up in front of you, right? Okay, this is a lymphoepithelial cyst. It is associated with HIV or in autoimmune Sjogren's. The HIV-associated lesions do not usually progress to lymphomas. That's one thing to know. And another important fact is that the lymphoepithelial cysts in children may exhibit monoclonality, but they do not progress to lymphomas, right? Now, I would just like to show you some tumors from the neighborhood which are not salivary tumors. So guess what this tumor could be? These are all our cases. So this is the tumor in the submandibular gland area. And all these were done many years ago, when sometimes the clinicians used to push her to do an FNA without doing the imaging. So, but I know even with imaging, we can come across this issue. So this one is a pilomatric one. See how basaloid the cells look. Of course, the giant cells over here could be a giveaway. I should always look at the enucleated squams in the background. Look at this one, right? This was again a tumor in the upper cervical region. It was sent as a salivary gland tumor, can you believe it? And somebody did the FNA. And later on, it was found to be a carotid body tumor. This is a PNET, which presented in a, I think, 16-year-old young child, girl, and this is what we saw. This was a PNET which was sent to us as a salivary gland tumor. Right. This one is pretty spectacular. Guess what this one is? We see this pretty commonly, you know, in this area. This is spindle cell lipoma. Right. See the ropey collagen, a little bit of ropey collagen, the fat adduced to the spindle cells. Right. So what are my top 5 concerns? We are now wrapping up. What are my top 5 concerns related to salivary gland FNA? What are the things that I want to remember? Because I think that forewarned, as they say, is forearmed. Remember, low-grade mucoepidermoid carcinomas masquerading as mucus retention cysts. So whenever you think something is a mucus retention cyst, please keep in mind you might be missing a low-grade mucoepidermoid carcinoma. The other one I've spoken about, mistaking epithelial myoepithelial carcinoma, which fortunately are very rare, as pleomorphic adenomas. Mistaking marginal zone lymphomas as reactive hyperplasia. You can keep on doing the FNA, patient keeps coming back, not responding to any form of therapy, and later on you do a flow cytometry and you find that this is a marginal zone lymphoma, okay? Or when the intermediate cells become more prominent. Missing metastatic squamous cell carcinoma in a sea of squamous cells, that can happen. That could be quite tragic. And a very important thing, not having any prior knowledge of imaging. So this is where I work, Mubarak Al-Kabir Hospital, Kuwait. That is a view of our work area. This is the place where we do our own FNAs. This is where we do, most of the slides that you have seen today, all of them are conventional smears. We are one of the first labs to start liquid-based cytology in FNA material, but we didn't continue with it. although we use liquid-based cytology extensively in non-FNA cytology like GIN cytology and exfoliative cytology, but we do not, we do not like to do liquid-based cytology on FNA material. We have our reasons. It's a controversial topic. We're not going to, we can have some other discussion some other time, right? And with this, I can only say that this is another view from the Haleakala crater with which I started my presentation. This is the sun just breaking through the clouds. It's a spectacular sight as it breaks through the cloud and the mist. I hope that with this talk, I have been able to at least do a little bit in lifting the mist over this difficult area of cytopathology, that is cytopathology of salivary glands. I'm still in the process of learning. I find this extremely difficult, salivary cytopathology. And thank you very, very much. Thank you for your time. And I part with one picture from Kuwait. Thank you. Yes, Dr. Nadeem or Dr. Indranil. Okay.
Thank you so much, sir. Sir, you didn't lift the mist a bit, you lifted the mist a lot, actually. That was wonderful, sir. That was such a lucid presentation. It was really a pleasure listening to you as always. Sir, I don't think we have any questions in the chat box. I have been constantly checking.
Okay.
Sir, I think it was really so lucid that no one has any doubts anymore.
Thank you very much. Thank you.
On behalf of West Bengal Cytology Society, I express my heartfelt gratitude for sharing your precious time with us, sir. It was wonderful to have you here. Thank you once again, sir. Thank you so much.
Thank you.
With that, we come to the next session of the evening. Medical science gets updated every day, and it is vital that we keep ourselves well informed about all the relevant changes so that we may serve our patients better. With that in mind, West Bengal Cytology Society would like to welcome Dr. Achal Kakkar to speak on recently described entities in salivary gland cytology. Dr. Kakkar is currently an associate professor in the Department of Pathology, AIIMS, New Delhi. She had done her MD in pathology from AIIMS, New Delhi. Her research interests are head and neck pathology and pediatric tumor pathology. She has a whopping number of 135 publications in national and international journals. She has been invited to contribute to chapters in 5th editions of WHO Blue Books. She has contributed a chapter entitled Head and Neck to the South Asia content in Robbins and Cochrane, Pathologic Basis of Disease, the book that has always been a must-read for all pathologists. She is the recipient of multiple awards, including the prestigious Dr. N.C. Nayak Award for Talented Young Pathologist by IAPM Delhi chapter. West Bengal Cytology Society is honored to have you here, ma'am. I would now like to request Dr. Achal Kakkar to please begin her presentation. Ma'am, please, if you could take over.
Good evening. Let me just share my screen. Is my screen visible?
Yes, ma'am.
Good evening, everyone. At the outset, I would like to thank the organizers, the organizing committee of the West Bengal Cytology Society for including me in the prestigious Professor Subir Kumar Datta Memorial CME. And I'm going to be talking about just a second. Yeah, so I'm going to be talking about the cytology of some recently described entities. And so salivary gland neoplasms, as Dr. Malik has already highlighted, are one of the most difficult areas of head and neck pathology, as these are rare tumors, and in most centers and pathologists do not see a high number of cases. Salivary gland tumors encompass a broad histological spectrum of tumors, as we've already seen. The WHO 2017 includes about 42 entities, and the next edition is going to include at least 4 to 5 new ones. These tumors have overlapping morphological features due to the similar cells of origin, and they have marked morphological heterogeneity within individual entities too. In recent years, the knowledge of the genomic landscapes of these tumors has increased and led to the identification of new entities as well as new subtypes of previously well-defined neoplasms. And it is definitely hard to stay abreast of all the novel findings. And I'm just talking about histology. So when we come to cytology, things are definitely going to be difficult. We've already seen some of the genetic alterations in salivary gland tumors. This is a more expanded list. And you can see that some of these are the ones which we are already familiar with, like the MAML2 in mucoepidermoid, the MYB fusions in adenoid cystic carcinoma, PLAG fusions in pleomorphic adenoma, which have now also been identified in about 50% of epithelial myoepithelial carcinomas. You have CTNNB1 mutations in basal cell adenomas. Clear cell carcinomas are characterized by the EWSR1-ATF1 fusion. Recently, the NR4A3 fusions have been identified in acinic cell carcinomas. Secretory carcinomas are characterized by the ETV6-NTRK3 fusions. Polymorphous adenocarcinomas are characterized by PRKD1 gene mutations, and the subtype, the cribriform adenocarcinoma of salivary gland, is characterized by PRKD1 gene fusions with a number of fusion partners. Some recently described entities are mucinous adenocarcinoma, which is typified by the AKT1E17K mutation. Intraductal carcinomas have been found to have the NCOA RET and other RET fusions. And the most recently described entity is microsecretory adenocarcinoma, which was first described in 2019. And all of these cases described since then have the MEF2C SS18 translocation. It's important to note that the cytology of some of these tumors is either not described or is described only in a few reports, which makes identifying them rather difficult. Can we detect what are the various methods of detection of these genetic alterations? There are a number of techniques like fluorescence in situ hybridization, PCR-based methods, as well as IHC using surrogate markers. But can we use these on cytology? So studies have shown in salivary gland neoplasms as well as in other cancers that these molecular tests can be applied to cytology on cell blocks, on extra smears that are prepared at the time of doing an FNAC, and also on destain smears. But most importantly, we have to realize that when we have FNACs, the material is always limited, and we first need to make a morphological diagnosis before we go on to apply these ancillary techniques. With this, I'll go on to my first case. This is a 41-year-old male who presented with a mass in the left parotid region. You can see that the smear is highly cellular. It shows some mucinous material in the background, and it has some cohesive fragments as well as dispersed cells. On higher magnification, we can see that there are different types of cells. You can see cells with abundant cytoplasm as well as cells with scant cytoplasm, which appear sort of like intermediate-like cells, whereas these cells which have abundant cytoplasm, some of them could appear squamoid, as seen here, and some cells have vacuolated cytoplasm. Here again, we can see that these cells which have scant to moderate amount of cytoplasm and round hyperchromatic appearing nuclei, these appear like intermediate cells, whereas these cells have a lot of cytoplasm in the cytoplasmic vacuolation. And again, you can see the mucinous appearing background. And here we have some fragments which have a little more cytoplasm, quite abundant, dense looking, and these appear to be squamoid cells. This is a gene sustain where you can see the abundant bubbly material which is seen in the background, as well as these cells, some with vacuolated cytoplasm and some with dense appearing cytoplasm. This was diagnosed as a mucoepidermoid carcinoma, and the patient underwent surgery. So on histopathology, what we can see is a tumor which has cribriform spaces, cribriform architecture, as well as microcystic and macrocystic architecture with abundant luminal secretions. You can see the presence of microfollicles, many of which have secretions within them, within the more solid appearing areas, as well as papillary cystic areas which are filled with abundant colloid-like secretions which have a scalloped edge. On high magnification, you can see that the tumor cells have granular eosinophilic cytoplasm, bland nuclei with fine chromatin. And the nuclei are round, uniform, vesicular with prominent nucleoli. And you can see that some of the cells have a hobnail appearance as well. This tumor was immunopositive for S100 diffusely, and we performed fluorescence in situ hybridization, and it showed the ETV6 gene rearrangement. As seen here, you have one normal yellow signal and one red and one green signal indicating a break apart. So we went back and reviewed the cytology, and sure enough, on some of the fragments, you can see these punched out rounded spaces, giving it a cribriform appearance. And these cells on GeneSAR, you can see they have multivacuolated, bubbly appearing cytoplasm and eccentric nuclei, as well as something akin to a hobnail appearance with the nucleus sort of extruding out of the cell. Immunocytochemistry was performed on a D-stain smear for S100, and you can see that S100 is positive. So secretory carcinoma is a recently described entity. It's a low-grade salivary gland carcinoma, which was included in the WHO 2017 for the first time. It is characterized by a morphological resemblance to breast secretory carcinoma, and it harbors the T1215 with the resultant ETV6 NTRK3 gene fusion. It most commonly occurs in the parotid, but also occurs in intraoral minor salivary gland locations. Histologically, majority of these were previously diagnosed as zymogen-poor acinic cell carcinomas. They have a lobulated pattern with fibrous septa. The architecture is quite diverse with microcystic, solid, tubular, follicular, and papillary cystic structures, which contain distinctive luminal secretions. Tumor cells have eosinophilic granular vacuolated cytoplasm with small uniform nuclei. On immunohistochemistry, the cells are positive for S100, GATA3, and mammoglobin. The differential diagnosis is acinic cell carcinoma, low-grade mucoepidermoid carcinoma, and intraductal carcinoma on histology. Coming to the cytological features, there usually is a mixed population of dispersed cells as well as papillary structures. If you see the papillae, they appear to have a jagged appearance rather than having a uniform community border. And you have this mucinous background, which does resemble mucoepidermoid carcinoma. On high magnification, you would identify some punched out circular spaces within the fragments, which is akin to the cribriform architecture that is seen on histology. You can appreciate the cytoplasmic vacuoles here as well. The tumor cells have uniform round nuclei with conspicuous to prominent nucleoli, abundant dense granular to vacuolated cytoplasm. Here you can see large cytoplasmic vacuoles, whereas other cells have more fine cytoplasmic vacuolation. Binucleation and multinucleation may be seen. The most important differential diagnosis is acinic cell carcinoma, and here you can see that these papillae have a more smooth border as compared to the previous cases. And here you have a frothy background, which is more granular appearing rather than mucinous. You also have a number of dispersed tumor cells accompanied by lymphocytes, as acinic cell carcinomas are frequently associated with a tumor-associated lymphoid proliferation. Within the papillae itself, you are able to identify the presence of acinar structures quite frequently. The cytoplasm of these cells is granular rather than vacuolated, and is similar to secretory carcinoma. They do have round nuclei with small conspicuous nucleoli, which may be located eccentrically. However, if you see the GeneSAR, you see that the cytoplasm does not actually contain empty vacuoles, but it appears granular due to the presence of zymogen granules. We can perform immunohistochemistry to diagnose acinic cell carcinoma. Here you can see that the tumor cells are positive for DOG1, and this case was also positive for NR4A3 rearrangement, as seen here. Recently, it has been shown that NR4A3 or NOR1 immunohistochemistry can be performed on cytology material with good sensitivity and specificity, and we should probably go ahead and try this. The other differential diagnosis is mucoepidermoid carcinoma. Here you see an abundant mucinous background. You have all the different cell types, the intermediate cells, the squamoid appearing cells, as well as the mucinous cells. And also the nuclei show more nuclear atypia than we usually see in a secretory carcinoma, even in a low-grade mucoepidermoid. The diagnosis of secretory carcinoma has some therapeutic significance, as the ETV6 NTRK3 fusion is a targetable genetic alteration. The NTRK genes encode for a family of 3 kinases, that is the TRK A, B, and C proteins, which play a pivotal role in neural development. And NTRK mutations as well as TRK protein expression are seen in a variety of tumors apart from secretory carcinoma, including colorectal and lung carcinomas, melanomas, and acute myeloid leukemias. And the most common mechanism for oncogenic activation of these TRK proteins is the fusion involving the NTRK genes. Now, TRK inhibitors are available which block the activity of the TRK A, B, and C proteins, and these drugs have been approved by FDA for solid tumors which harbor the NTRK gene fusions. And recently, pan-TRK IHC has been identified as a reliable surrogate for genetic testing with high sensitivity and specificity, suggesting that it may be a promising alternative, inexpensive screening test. So this is our case in which we have performed pan-TRK IHC, and you can see nice nuclear as well as cytoplasmic positivity, which is a reflection of the NTRK gene rearrangement present. This is a D-stained smear, MGG stained smear, on which we have just recently attempted to perform fluorescence in situ hybridization, and this shows a rearrangement of the ETV6 gene. So to summarize, secretory carcinoma has characteristic cytological features that recapitulate the histology. Mucoepidermoid carcinoma and adenoid cystic carcinoma are close morphological differential diagnosis. Immunocytochemistry and FISH on cell blocks can help us to make an accurate diagnosis on cytology. But do we really need to do these? Not necessarily. If they are unavailable, we call it a carcinoma and characterize it further as either a low-grade or a high-grade carcinoma. Right? So this would be a low-grade carcinoma, and you say that the cytomorphology favors secretory carcinoma over the other differential diagnosis, because the management of a low-grade carcinoma would be the same, irrespective of what the exact diagnosis is. We'll go on to the next case. This is of a 48-year-old male who was a smoker for 10 years, who presented with voice change, dysphagia, and odynophagia for 1 month, associated with weight loss. On examination, he was found to have a 4 centimeter size right-sided neck mass. An FNAC was performed which showed paucicellular smear with abundant mucinous material and few cellular fragments. So you can see that some of these are cohesive fragments, whereas there are dispersed cells in other areas. And some of the fragments showed large polygonal cells with scant to moderate amount of cytoplasm, vesicular nuclei with conspicuous nucleoli. Here you can see that these cells again have scant to moderate amount of cytoplasm. Whereas in other areas, there were cells which appeared to be squamoid in appearance. You can see the nuclear pleomorphism here. And then there were also cells which showed finely vacuolated cytoplasm as well. With these features, the possibility of a metastatic mucoepidermoid carcinoma was considered. Now we look at some other areas of the smears, and what is it that we see here? These appear to be ciliated columnar cells. This is the GIMSA, which is showing the same. So what are these cells doing here? Is this a metastatic mucoepidermoid carcinoma from an unknown primary, which is quite an unusual presentation? We don't usually see unknown primary mucoepidermoid carcinomas. Are these some normal ciliated columnar cells, or are they a part of the tumor? Because you don't expect to see ciliated columnar cells in the neck at this site. So this was reported as a poorly differentiated carcinoma. No other mass was detected of imaging, and so a core biopsy was performed. So here is the core biopsy. You can see there are multiple cores of fibrocollagenous tissue with only small fragments of tumor. On higher magnification, you can see this small fragment of tumor is composed of various cell types. You have larger polygonal cells which have a squamoid appearance, some vacuolated cells, as well as some cells with scant to moderate amount of cytoplasm. Considering this was a very tiny fragment, it was reported as small fragments of atypical cells suspicious for metastasis, and a repeat biopsy was undertaken. Here again, you can see that we don't have too much of tumor in this, but you can see that these cores are infiltrated by some solid islands of tumor cells, as well as some glandular structures. You can see that these solid islands have what appear to be squamoid cells, as well as some clear cells. And the glands are lined by pseudostratified ciliated columnar epithelium. These cells have abundant cytoplasm. And here towards the abluminal aspect, you have some smaller cells with scant cytoplasm. When we look at the higher magnification of these glandular structures, you can see that these cells have cilia on the apical aspect, which are well seen here. AB Pass highlighted the mucin within the cytoplasm of these cells. And this is CK7, which stained the luminal cells, whereas P40 stained the cells on the abluminal aspect. So when do we see cilia in tumors? Cilia are normal microscopic structures that are seen in columnar cells of the respiratory and female genital tract. Because they're seen in fully differentiated glandular cells, the presence of cilia is considered compelling evidence of a benign process. However, few malignancies, such as adenocarcinomas of the female genital tract and the esophagus and stomach, do show the presence of cilia. In the head and neck, until recently, they were only described in thyroid mucoepidermoid carcinomas. However, recently, two novel entities have been described to demonstrate the presence of cilia, and these are ciliated mucoepidermoid carcinoma and HPV-associated ciliated adenosquamous carcinoma of the oropharynx. So in a neck mass, as in the present case, metastasis from either of these should be considered. The differential diagnosis will also include benign conditions such as a branchial cleft cyst. Ciliated mucoepidermoid carcinoma, a single case has been described till date, which was that of a 47-year-old female who presented with cervical lymph node metastasis and was subsequently found to have a primary in the base of the tongue. On histology, you can see that it shows presence of mucinous, intermediate as well as squamoid cells in cystic and solid growth patterns. And the eosinophilic columnar cells are seen here, which harbor numerous well-formed cilia. The tumor cells had small round monotonous nuclei with inconspicuous nucleoli, and had rare mitotic figures. And on performing FISH, they demonstrated the presence of an enamel-to rearrangement, confirming their identity as a mucoepidermoid carcinoma. The other entity that we're talking about is the HPV-associated ciliated adenosquamous carcinoma. The typical presentation of this tumor is of cystic lymph node metastasis with an unknown primary site, and some of these patients are subsequently found to have an oropharyngeal primary. On histology, you see typical areas of non-keratinizing squamous cell carcinoma, which are interspersed with glandular spaces, which are lined by ciliated columnar cells. Contrary to the previous lesion, here you can see nuclear atypia, mitosis, as well as necrosis. And being associated with HPV, this tumor is diffusely immunopositive for P16, and it demonstrates high risk HPV by in situ hybridization. How would we differentiate between these two tumors? As we know, mucoepidermoid carcinomas are characterized by mucinous intermediate squamoid cells in a solid cystic growth pattern. And certain criteria have been defined to distinguish adenosquamous carcinomas from mucoepidermoid carcinomas, including the presence of surface squamous dysplasia or carcinoma in situ, pronounced keratinization, the absence of intermediate cells, and overtly malignant cytology, and the presence of marked nuclear atypia, mitosis, and necrosis. However, all of these would not be applicable in a metastatic site. Certainly, we would not expect to see the presence of squamous dysplasia or carcinoma in situ, making the task even more difficult. Also, although ciliated adenosquamous carcinoma is HPV associated, P16 is not helpful in this differential diagnosis because it is positive in ciliated mucoepidermoid carcinoma as well as classical mucoepidermoid carcinoma in about 50% of cases, and also in the other differential diagnosis, that is branchial cleft cyst, which again 50% of which do show P16 positivity. So to make to make a diagnosis here, we would need high risk HPV in situ hybridization and mammal-to rearrangement. We did perform P16 in the current case, and as you can see, it is showing only very patchy positivity, not the diffuse nuclear and cytoplasmic block positivity that you would expect to see in an HPV-associated tumor. Unfortunately, there was no more tissue left in the block to perform the rest of the test, and the patient did not follow up with us. But seeing this P16, I would think that this was a case of ciliated mucoepidermoid carcinoma. In the take-home message from this case is that in an FNAC from head and neck sites, the presence of cilia does not always indicate that it is a benign lesion, and we should always think of these two novel entities. And if we have cell blocks, we can perform ancillary tests. If not available, go ahead and ask for a biopsy. Along with the ciliated variant of mucoepidermoid carcinoma, I'd just like to put in a bit about the Warthin-like variant of mucoepidermoid carcinoma, the cytology of which has not been described in literature. On histology, you can see on low magnification that it very closely resembles a Warthin tumor with abundant reactive lymphoid tissue and cystic spaces, which are lined by epithelial cells. But as you can see here, this is not a bilayered oncocytic epithelium, but a rather haphazard-looking epithelium. And here you can see that there are small areas of invasion. Usually this variant does have areas of classical mucoepidermoid carcinoma. At least a few small foci are usually present. And here you can see the authors have shown that the difference between the haphazardly arranged epithelial layers of the Warthin-like mucoepidermoid carcinoma in comparison with the organized bilayer of Warthin tumor. As I mentioned, the cytology is not being described till date, but I would expect that you would see some mucinous and intermediate cells along with abundant lymphocytes, and some nuclear atypia would be present, which you do not usually expect to see in a Warthin tumor. An important differential diagnosis here. Sorry, just a second. Yeah. An important differential diagnosis here would be the presence of mucinous metaplasia in a Warthin tumor, which may be seen on occasion. So this is a case where you can see fragments of oncocytic cells. There was a lot of mucinous, bubbly mucinous material in the background along with lymphocytes, and some cells with vacuolated cytoplasm were also seen here. And on histology, this tumor was a classical Warthin tumor. However, there were foci of mucinous metaplasia, as are seen here and highlighted by AB pass. So we should always keep this differential diagnosis in mind before we go ahead and call something a Warthin-like mucoepidermoid carcinoma. And correlation with imaging would be extremely important in this situation. Coming to the next case, this was a 26-year-old man who presented with a painful swelling over the hard palate for 8 months. And on intraoral examination, he was found to have a 4 centimeter size submucosal mass. And he did not have any lymphadenopathy. CT showed a heterogeneously enhancing mass involving the hard palate with bony erosion. And an FNAC was performed from this. We usually do not perform intraoral FNACs, and this was an exception. As you can see, the smears here are not very cellular. However, there are few cohesive fragments of tumor cells, and which are seen here. And on higher magnification, you can see that these fragments have a papillary architecture. Some of the papillae have some matrix within their pores. The tumor cells are have uniform nuclei, which are round to ovoid, and scant amount of fluffy appearing cytoplasm. And if you're thinking about the diagnosis, I've highlighted some of the features here, which I will come to shortly. This case was reported as a polymorphous adenocarcinoma, and the patient underwent surgery. So here you can see the excised specimen, which has solid areas, as well as you can see these nice glomeruloid appearing areas. On higher magnification, the more solid appearing areas had a cribriform architecture with these punched out spaces, as well as glomeruloid structures with a peripheral row of palisaded cuboidal cells, as well as small papillary finger-like projections. On higher magnifications, the tumor cells have moderate amount of eosinophilic cytoplasm, and the nuclei have a ground glass appearance, or as well as show the presence of nuclear grooves. These cells are immunopositive diffusely for S100, and the peripheral layer of cuboidal cells is highlighted by myoepithelial and basal markers like CK56 shown here, as well as smooth muscle actin. This patient subsequently developed lymph node metastasis, which was excised. And here you can appreciate how the nuclei do have an often ani appearance or ground glass appearance similar to that of papillary carcinoma of thyroid. So the diagnosis in this case was cribriform adenocarcinoma of minor salivary gland. We look back at the cytology, and again, you can see the punched out circular spaces within the fragments, which would correlate with the cribriform architecture seen on histology. This is a glomeruloid structure with a narrow stalk, as well as some papillary tips, which correspond to the histological features that we saw already. The cells here, they have cytoplasm, which has been described as fluffy due to it being very fragile. The cell nuclei have powdery chromatin and show the presence of nucleoid grooves, as well as intranuclear cytoplasmic inclusions. The cribriform subtype of polymorphous adenocarcinoma has a distinctive neoplasm, which was first described arising in the posterior oral tongue and the base of tongue. And due to this location, it was designated as CAT, or cribriform adenocarcinoma of the tongue. Subsequently, it was described in other minor salivary gland locations, including the soft palate, the retromolar buccal mucosa, lingual tonsils, upper lip, floor of mouth. And the name was changed to cribriform adenocarcinoma of minor salivary glands. Its most striking feature is the similarity of its nuclei to those of papillary carcinoma of thyroid, which led to the presumption that it may have an origin in the lingual thyroglossal duct and large. And papillary carcinoma thyroid is an important differential diagnostic consideration in nodal metastasis. There's a debate on the taxonomy of this entity. The WHO 2005 called it a possible variant of polymorphous low-grade adenocarcinoma. In WHO 2017, it was called a cribriform variant of polymorphous adenocarcinoma. And the WHO 2001 is probably going to call it polymorphous adenocarcinoma cribriform subtype. The cribriform adenocarcinoma differs morphologically as well as behaviorally from conventional polymorphous adenocarcinoma, which is why it is important to distinguish the two. It occurs predominantly in the tongue, unlike polymorphous adenocarcinoma, which is more common in the palate, the buccal mucosa, and the retromolar trigone. It has limited variation in growth patterns, being mainly cribriform, glomeruloid, solid, and papillary, while we are well aware that polymorphous adenocarcinoma has diverse growth patterns, including tubular, papillary, solid, cribriform, streaming columns of single cells, and narrow trabeculae in concentric whorls, giving an eye of the storm appearance or a targetoid appearance. While P63 is diffusely positive in polymorphous adenocarcinoma and SMA is negative, basal myoepithelial markers like P63 and smooth muscle actin stain the peripheral cuboidal cells of the glomeruloid structures in cribriform adenocarcinoma. The striking nuclear feature is that of PTC-like pale, optically clear or orphan annii of ground glass nuclei, while the nuclei of polymorphous adenocarcinoma have minimal hyperchromasia. Cribriform adenocarcinoma has a propensity for lymphovascular invasion more than perineural invasion, while polymorphous adenocarcinoma frequently shows perineural invasion. While polymorphous adenocarcinoma has frequent local recurrences, lymph node metastases are extremely rare. However, cribriform adenocarcinoma has early lymph node metastases, which are often bilateral, but no distant metastases. They do have similar molecular genetic profile because they both show alterations in the same gene. However, while polymorphous adenocarcinoma shows point mutations in the PRKD1 gene, cribriform adenocarcinoma shows fusions of the PRKD1 gene, usually with ARID1A. However, other variant fusions can also be seen. Many authors have regarded cribriform adenocarcinoma as a distinct entity. However, the overlapping morphology and genetics suggest that it represents a spectrum of lesions driven by PRKD gene alterations, and that is probably going to reflect in the upcoming WHO classification as well. Interestingly, the PRKD1 mutation and gene rearrangements are mutually exclusive. And studies have shown that the fusion-positive tumors as a group are associated with a higher rate of involvement of the base of tongue, higher percentage of chromatin clearing and papillary growth, lower rate of single-file architecture, and a high rate of nodal metastasis, more aggressive clinical behavior, and they do require additional management like neck dissection, which would not be required in the tumors harboring the PRKD1 mutation. Also, Sebastio et al. Have found that 10% or more of papillae are significantly more common in fusion-positive tumors. So the percentage of papillae may be predictive of the underlying genetic alteration as well as the outcome. So once you make a diagnosis of cribriform adenocarcinoma, the patient would require a neck dissection, while it would not be required in a polymorphous adenocarcinoma. I'm having some difficulty. Okay. On cytology, what are the differential diagnoses? Polymorphous adenocarcinoma, as described in literature, has trabecular as well as pseudopapillary structures, which have a fibrous stromal core, which may show the presence of small hyaline globules. The cells are uniform polygonal, with medium sized, with moderate amounts of agranular cytoplasm. The nuclei have vesicular chromatin and small distinct nucleoli. However, it's important to note that most of these reports of the cytology of polymorphous adenocarcinoma that are available in literature were before cribriform adenocarcinoma was recognized as an entity. So the cytology that is described would have overlapping features between both of these entities and would be described as polymorphous adenocarcinoma. The important features which would help you to differentiate from polymorphous adenocarcinoma is the presence of glomeruloid structures, cribriform architecture, and the presence of nuclear grooves and pseudoinclusions. The other differential diagnoses include adenoid cystic carcinoma and pleomorphic adenoma, which have been covered extensively in the previous talk. But most importantly, at a metastatic site, one should always consider the differential diagnosis of a metastatic papillary carcinoma of thyroid, which would show the presence of colloid, swirling within flat sheets, and of course TTF1. These are the things which would help you to distinguish from this. So the take-home message in this case is that due to the high propensity for lymph node metastasis, the FNAC diagnosis of cribriform subtype of polymorphous adenocarcinoma has significant clinical implications. On cytology, though it bears some architectural similarity to polymorphous adenocarcinoma, typical nuclear features, the presence of cribriform and glomeruloid structure, would favor the cribriform subtype over a classical polymorphous adenocarcinoma. Lastly, the identification of characteristic nuclear features at a metastatic site in the absence of a thyroid nodule should prompt evaluation of the oral cavity in patients with an unknown primary. Some other recently described entities of which I'm yet to come across a cytology, one of which is sclerosing polycystic adenoma. This is a circumscribed salivary gland neoplasm, which was previously known as sclerosing polycystic adenosis. However, mutations were identified in the PI3 kinase pathway, most frequently in the PTEN gene, which identified it as a neoplasm. Histologically, it is composed of large acinar cells which have brightly eosinophilic cytoplasmic granules, accompanied by variable ductal components which may have foamy, vacuolated, or apocrine cells lining them. The cytology is described in a couple of reports only, and the features that are described most frequently are the presence of cystic type proteinaceous material in the background as seen here, the presence of syncytial ductal epithelial cells, the presence of different types of cells within a fragment such as ductal, apocrine, and sebaceous-like cells with finely vacuolated cytoplasm accompanied by foamy histiocytes and oncocytes. To conclude, molecular testing has led to refinements in the classification of salivary gland neoplasms and led to the emergence of novel entities as well as morphological subtypes of well-defined tumors. Preoperative diagnosis has significant clinical implications, necessitating awareness of the cytomorphological features of these recently described tumors. However, the diagnosis on cytology may be challenging because there are limited descriptions in literature, such as for secretory carcinoma, and the cytology of some newly defined entities has not been described as yet at all, such as microsecretory carcinoma. However, with a high index of suspicion, the knowledge of the cytomorphological features, and the use of ancillary techniques, diagnosis of these novel entities is possible on cytological material. I would like to acknowledge the contributions of my students and colleagues. Chetna and Ria work with me on salivary gland tumors. Diksha and Aruna are the ones who have standardized the procedure for fluorescence in situ hybridization on gene-sustained smears, which I performed in one case, and the staff and all my staff and students at the Head and Neck Lab. Thank you.
Thank you so much, ma'am. That was such an enlightening presentation. I'm sure all the delegates will be immensely benefited by it. Ma'am, we don't have any questions, but the chat box is really flooded with lots of comments, both for you, and I can see that Dr. Malik is still here, logged in with us. So if you could just allow me to read these out. Dr. Nadine tells us that it was an excellent presentation, Dr. Mrinmoy. You are an excellent teacher. It's a pleasure listening to your lectures. God bless you. Then we have, I'm sorry, but my screen, okay, one, please, my apologies. I will just read the next. Okay, Dr. Indrani Chakraborty has messaged that brilliant presentations from our speakers, much appreciated. Dr. Shravasti Roy, she tells us excellent and illuminating presentations. Dr. Krishti Chatterjee, thank you, Dr. Malik sir, Dr. Kakkar ma'am, for the wonderful curtain raisers on salivary gland neoplasms. Dr. Santosh Kumar Mondol, nice lucid presentation. Dr. Malik, you have covered almost every case in salivary gland cytopathology. And here again, we have Ria Mahendru, who has messaged, nicely organized, everything looks perfect. And again, there is someone called Priscilla Babu. And everyone is saying, ma'am, it is Dr. Achal Kakkar, superlative as usual. And Dr. Bhatia says, excellent talk. So ma'am, these messages all tell us exactly what we are feeling right now. Thank you so much, ma'am. Thank you, sir. Both of you have been such wonderful speakers, and we're so glad to have you here. Nadeem sir also tells us, excellent Anchal Nadi. All right. Again, that was great. Okay, so on behalf of West Bengal Cytology Society, I take this opportunity to thank the both of you, Dr. Anchal Kakkar. Thank you so much for being with us here today. Thank you, ma'am. Thank you so much.
Thank you so much once again for inviting me. Thank you.
Thank you. It was a pleasure having you here. Thank you, sir. Thank you, ma'am. That was great. Thank you. We move on to our next session of the evening. Now we have a very special session, the Milan system for reporting salivary gland cytopathology. And to speak on this topic, we have a very special person who is joining us across time zones, Dr. Christopher Vanden Boe. He is currently the Associate Professor of Pathology and Oncology, Johns Hopkins Medical Center, the Associate Director of Cytopathology, and the Program Director of Cytopathology Fellowship. He is a member of the College of American Pathologists Cytopathology Committee. He has led the pelvic washings chapter of the International System for Reporting Serous Fluid Cytopathology. He also leads 2 chapters for forthcoming updated version of the Paris System for Reporting Urinary Cytology. He served on the American Society of Cytopathology's Scientific Program Committee for 4 years and is currently chair of the Clinical Practice Committee. He has published several books and has over 100 peer-reviewed scientific papers. He serves on numerous editorial boards of esteemed journals. It is an absolute honor for the West Bengal Cytology Society to have such a decorated personality on this platform today. Thank you so much for joining us here, sir. The delegates, while the session is going on, are requested to type out their comments and queries in the chat box during the session. I would now like to request Dr. Christopher to kindly begin his presentation. Sir, please, if you could take over.
Thank you so much. It's an honor to be here. Thank you for the wonderful introduction. And I can tell from the last presentation that this has been a superb morning for me, but evening for you all. So thanks for having me. I'm just going to set up my screen here and share it with you. And are you able to see it okay?
Yes, sir. Yes, sir.
Yes,
It's
sir.
visible.
Yes, sir. Yes, sir.
So I mostly do cytopathology. We're kind of an interesting department at Hopkins where our cytopathologists mostly do cytopathology. And of course, I have excellent surgical pathology colleagues that I work with. So I don't always see the histology directly for all the FNA specimens I have. And so I have a perspective that's a little bit a little bit narrow for looking at things from cytopathology. And I've always struggled with salivary gland cytopathology. And when the Milan system came out, it helped me so much. It really provides such a great framework for understanding the limitations of cytopathology. And as the last lecture showed, with these new ancillary methods in a more specific ancillary test IHC stains that we have now, cytology with a small specimen and a cell block, we can even start to be a little bit more definitive. But since we're often limited without the histologic specimen, we really have a good framework with the Milan system for expressing our doubt in differential diagnoses with entities, as you'll see. These are some of my disclosures. They aren't relevant to this particular talk. So we'll give an introduction to the Milan system, which I know many of you are familiar with and are already using, but let's talk about it, especially for those that may not be as familiar with it, and define the categories and give some examples of what each category really means. And this is really a pattern-based approach, which is very helpful speaking as a cytopathologist. We'll talk about a few recent publications regarding the performance of the Milan system. There have been many publications, and out of interest of time, I won't go into this into great detail, but just to give some thought-provoking recent articles and a summary article, a meta-analysis of performance of Milan system. And then if we have time, I have a few cases that are salivary FNA cases that I found were very interesting and challenging, in how maybe the Milan system can help us with these types of cases. So these are the categories of the Milan system. And so you can appreciate that this goes beyond your typical categories in cytopathology, where we have benign, malignant, atypical, and suspicious. And just to highlight some of these sort of differences, is our atypical category is called atypia of undetermined significance, or AUS. You know, these systems all have slightly different names for the atypical categories, but here with Milan we have AUS. And what we can appreciate is that the Milan system has a neoplasm category. So we appreciate that a lot of times in salivary gland FNA, we may not be able to give a definitive diagnosis. A lot of what we're struggling with primarily is this a neoplasm or is this not a neoplasm? If we can go beyond that and say more than that, that's great, and we can give a specific entity that's benign or malignant, that's even better. But our primary goal initially, at least, to decide is what we're looking at on FNA a neoplasm or not a neoplasm. So we have a neoplasm category, and then we have the typical suspicious for malignancy category, and then a malignant category. So when I think about the Milan system categories, this is sort of how I think about the categories. So if we call it non-neoplastic, we're saying we know for certain, and in cytology, certain is about 99%. It's not always 100% because there's always these pitfalls, but we're fairly certain with great confidence that a neoplasm can be excluded based on what we're seeing. And a lot of times that means we're recognizing specific findings along with the clinical radiologic impression that a neoplasm can be excluded. If we can't exclude a neoplasm, or we're quote unquote suspicious for a neoplasm, but we can't quite get to neoplasm, that's where the AUS category is helpful. Usually with experience, we can feel relatively comfortable whether something gets to neoplasm or not. And so a lot of times I'm not in the AUS category. But however, this is a useful category when we're not sure we're doing neoplasm. If we are certain that we are reached a neoplasm, we now have to decide whether we're certain that it's benign. So typically we look at the findings and we can definitively identify something as a specific entity that we know is benign. We're in the benign category. However, a lot of times we don't know for sure, as we'll see. We're not sure whether, we know it's a neoplasm, but we're not sure whether it's benign or malignant. And that's where this category SUMP, salivary gland neoplasm of certain malignant potential, comes in handy. And this is a category, despite its unusual name and an unusual acronym, is a category that we use quite often. We find ourselves in a situation where we know the findings are neoplastic, but we're not absolutely sure because of limitations in cytology, whether the entity is malignant or not. If we can definitively identify the entity and it's malignant, then we can get to the malignant category diagnosis. If we're not sure exactly what the entity is, but the cells are just in your face, pleomorphic and atypical, and there's no way it's not malignant, even though you can't completely categorize it, you can call it malignant. So these are sort of the ways this is how I sort of envision and use the Milan system categories. Now, this is a table from the Milan publication, and this is before data was published from different institutions about what the risk of malignancy in each category was. But this is what the authors envisioned the rate of malignancy goal would be for each particular category. So this may not hold true in real life as we gather more data and look at it. But as you can see, the risk of malignancy for something called malignant would be approximately 90%. And the follow-up would be surgery. If you call something suspicious for malignant, the risk of malignancy would be greater than 50%, 60%, maybe not quite to the rate of malignancy, and the follow-up would be surgery. If you call something neoplasm and you think it's benign, there should be a very low chance that that patient actually has a malignancy on follow-up. But of course, for many benign neoplasms, they may have received surgery anyway. And for the sump category, about a third of all cases will end up being malignant, and these cases would typically need surgery. So that leaves us with these other categories that are more indeterminate. AUS, this may require a repeat FNA or surgery. So this is a situation where you look at the findings and you see, why was it called AUS? You talk to the surgeon, you see what their impression is, you see maybe what the patient would prefer to happen for management. Perhaps the specimen was not very good, was not very cellular, and the repeat FNA is more appropriate. Perhaps the specimen is very cellular and it's just uncertain what the diagnosis is, and a repeat FNA would not be helpful. And therefore, a surgery is required for a definitive diagnosis. Non-neoplastic, risk of malignancy should be low because you are thinking that this is definitively a non-neoplastic finding, but of course, cytology is never 100%. And then non-diagnostic, it's hard to say, but risk of malignancy, perhaps 25%. And typically, this would require a repeat FNA to try to obtain a diagnostic specimen. So what defines a non-diagnostic specimen according to the Milan system? Well, generally insufficient cellular material for a cytologic diagnosis. In this initial version of the Milan system, this is based on the Bethesda system for reporting thyroid cytology, which uses approximately 60 epithelial cells for being diagnostic. So if you have less than 60 cells, typically that can be a general cutoff, at least in this version, for a non-diagnostic diagnosis, keeping in mind that as evidence continues to be gained on this category, there's some flexibility in its use. One exception to the cellular criteria is the presence of matrix material or mucinous cyst contents. So if you see matrix material or mucinous cyst contents, even if the specimen is otherwise acellular, this gets you into an atypical category diagnosis, as we'll see. So it's very important to recognize benign salivary tissue on FNA, and I'm sure that this was covered in part in previous lectures. So FNA of salivary gland can sometimes produce a large amount of normal tissue, and because in cytology we often use cellularity of a specimen to give us the impression of a hypercellular specimen, and the fact that we're sampling a lesion, the presence of a lot of acinar tissue can sometimes be misleading into thinking that we actually sampled something. So the typical grape-like architecture, which is seen at this particular magnification, can be very helpful. This, of course, being more of a classic grape-like architecture of normal acinar tissue, which some people who are not as familiar with cytology may always brought up to me in the past, well, if you FNA this, how can you be sure it's not an actinic cell carcinoma? And as you've seen and will see and probably know if you're experienced, the FNA of actinic cell carcinoma typically does not have this normal grape-like architecture of acinar tissue. So it's not true that seeing something like this, this is actually reassuring for benign salivary tissue. Now, as I mentioned, matrix material only, something such as this, generically described as simply myxoid material. This could be mucin, this could be mucin from a tumor, this could be mucin from a retention cyst, is indeterminate for whether there could be a neoplasm or not, but certainly increases the risk of a neoplasm to the extent that this should be called AUS and not non-diagnostic. Another example here, a globule that might be seen in an adenoid cystic carcinoma, but here you see it. You can actually probably pick out some of the cells in the background, but if you just mostly see a globule and you think, well, this is relatively acellular, I should call it non-diagnostic, the Milan system recommends that matrix material, even with scant cellularity, be called AUS. This is, I do take some tables from the Milan system that I think are relevant points. So some examples of samples that may warrant a note or a comment. So if you do see only benign salivary tissue, you should say that while this is non-neoplastic, you see salivary gland elements only, this does not explain the presence of a clinical or radiologically defined mass. So on FNA, we should be targeting a mass. We shouldn't be just sticking it at random into the salivary gland. And so if we don't have an explanation for a mass on our material, we have to have a note that says, this does not explain the presence of a mass. If you only see necrotic debris, this is considered non-diagnostic, but does raise the possibility of a neoplastic process. In non-mucinous cyst contents, we recommend cyst contents that in FNA be repeated if clinically indicated. So moving into the non-neoplastic category, typically these are entities that we could recognize as being specific entities that we know are not neoplastic. And typically, if we can recognize an inflammatory process, we should be very cautious in going too far up in our category diagnoses. So one example that, depending on your experience with cytology, is granulomatous inflammation. Granulomatous inflammation, where you have fragments of epithelioid histiocytes seen here with their curved nuclei. They don't all have that kind of curved nuclei, but some do, the boomerangs, with lymphocytes in the background that are often associated with the epithelial fragment. Sometimes granulomatous, granulomatous inflammation or clusters of epithelioid histiocytes can look epithelial on cytology and give you the impression of an epithelial fragment, maybe with atypia or possibly even an oncocytic type fragment with their abundant cytoplasm. And even if you don't think it's atypical or malignant, may give you the impression of a neoplasm, especially for those that may not be as experienced. More classic example of granulomatous inflammation with small epithelioid histiocyte aggregates with polymorphous lymphocytes in the background. And here, of course, the streaking of the chromatin of the lymphocytes out away from a fragment is always an indication in cytology that you're potentially dealing with an inflammatory process, even if this is not recognized as granulomatous inflammation. If you have a correlate to thyroid FNA, where you have epithelial cells or follicular cells with lymphocytes embedded in them, that could be a suggestion of Hashimoto thyroiditis, for instance. And so this sort of finding, even though this is very exuberant right here, even if you see some lymphocytes within epithelial fragments, or the streaking that should suggest the presence of lymphocytes, should potentially give you some caution and hold back. How do you deal with a population of polymorphous lymphocytes? Well, this is negative or non-neoplastic, assuming you're able to also obtain material for flow cytometry that can prove that this is not a clonal population. While there have been studies to show that cytology can sometimes identify typical populations of small lymphocytes that may be associated or diagnostic of a small lymphoma, typically in our practice and what the Milan system recommends is that polymorphous population of small lymphocytes really be evaluated by flow cytometry before you completely reassure someone that it's non-neoplastic. If flow cytometry is not obtained, the Milan system technically requires you to put it in the AUS category, but of course you can put a note saying that you see polymorphous mature lymphocytes. You could exclude an epithelial neoplasm in this case and maybe recommend flow cytometry and a repeat sample if there's any suspicion of a lymphoma. Sialadenitis can cause a lot of diagnostic difficulties in salivary gland FNA. So this is an example of lymphoepithelial sialadenitis. So remember that I mentioned that the association with many mature lymphocytes with epithelial cells should always be regarded with a bit of caution. Lymphoepithelial sialadenitis is often associated with Sjogren's syndrome, but not always. And in this case, you have basically atrophic ductal epithelial cells that have inflamed lymphocytes in it. Sialadenitis can often change the structure of the normal salivary gland tissue. And so in this example, you may see the normal grape-like architecture of the acinar cells that is helpful. And of course, the fact that the lymphocytes are embedded within this tissue is helpful for deciding that this is just a benign reactive process. But when the epithelial cells do not have that grape-like architecture anymore, it can cause some diagnostic difficulty. The AUS category, as I mentioned, are for samples indefinite for a neoplasm. A neoplastic process cannot be excluded after examination of all the cellular material. And the majority of these FNAs will represent reactive atypia or poorly sampled neoplasms. And so I do think it's important to give the clinician some idea of why you're calling it AUS. Is this because it's poorly sampled and a repeat FNA may be helpful? Or is it atypia a true atypia within a cellular population that cannot be determined whether it's strictly reactive or neoplastic? As I mentioned, mucin is clean mucin, that is acellular mucin, is a finding that could be associated with a neoplasm, a mucinous neoplasm, and that may be the only finding in the FNA of a low-grade epidermoid carcinoma. And so therefore, the presence of clean mucin without any cellular material to get you into a higher category should be considered at least AUS. This is one beautiful example of material that is mucin. Mucin may be a little bit more challenging. It may be more mixed together with what may be actually proteinaceous type fluid from a cyst. And so when mucin is very thin, that can be one particular challenge. I would say if you're feeling that that is possibly mucin, that you should go into an AUS category and be a little bit maybe more non-specific about what you're seeing, such as mucoid material or myxoid material. Small atypical fragments. So this may just be an example of an FNA. You see a small fragment. It has some disorganization. It's not clearly in that grape-like architecture of the acinar tissue, although you can imagine this could be metaplasia from sialadenitis. This could be other types of squamous metaplasia, et cetera, as we can get into a little bit later. But certainly there's some anisonucleosis, some disorganization within the fragment. If you saw this in a cellular amount of this material, you could get into a higher category. But if you just saw a few atypical fragments, that gets into the AUS category. Maybe a recommendation that a repeat FNA should be done to see, can we get more of these cells to evaluate them? As I mentioned, if flow cytometry is not performed in a polymorphous lymphocytic population, that is under the AUS category, technically speaking. So getting into the really heavy hitter category of neoplasm, broken down into either benign neoplasms or SUMP. These are where a lot of our diagnoses are made because so many salivary gland neoplasms that are evaluated by FNA are benign, and many of them are also fall into the SUMP category if they're malignant because we can't be absolutely sure whether they're benign or malignant. So the category benign neoplasm is reserved for benign neoplasms diagnosed based on established cytologic criteria. And I know the last lectures that you had really gave a lot of great examples of cytologic pictures where you could potentially make a definitive diagnosis in some of these instances. So the category includes things like classic cases of pleomorphic adenoma, Warthin tumor, and lipoma, et cetera. There are some pitfalls I would caution you as we go on that some of these entities that we see in textbooks and we think are straightforward, as you know, as you get more experience and you've called things Warthin tumor, et cetera, and then you find out you're wrong, you realize that some of these things that seem straightforward are not always as straightforward as you'd like them to be. And so unfortunately with experience, sometimes you learn that maybe SUMP is better than calling something definitively benign or potentially AUS. So here's a list of some things that the Milan system says might fall under the benign neoplasm category: pleomorphic adenoma, Warthin tumor, oncocytoma, lipoma, schwannoma, lymphangioma, hemangioma, things that you can look at on cytology and be fairly certain you can make a diagnosis in some instances. Classic pleomorphic adenoma, what you would really like to have is the fibrillary matrix material. Ideally, you have a Giemsa-like preparation where this can look very distinctive. It is less distinct on the Pap stain, as seen here, almost more of a mucoid or mixoid type material. Ideally, you have the cells embedded within the matrix material and not around on the edges. Typically, this appearance is classic, and really there's not a lot of pitfalls when you see this particular appearance. Usually it is almost certainly a pleomorphic adenoma. A Warthin tumor, you have classic papillary structure of oncocytic cells and a background of polymorphous lymphocytes, and ideally, which isn't as demonstrated as well here, but granular debris. I won't spend too much time on this, but Warthin tumor can be a huge pitfall. Sometimes you see something that you think is a Warthin tumor, but it's not. My recommendation is to see all three components, a fairly cellular amount of the oncocytic cells and papillary structures with the lymphocytes, with the granular debris before you definitively call something a Warthin tumor. Schwannoma can be somewhat challenging, at least from my perspective, on FNA alone if you don't have material. I often see schwannoma as something that appears to have both a spindle cell population mixed together with cells that appear more epithelioid. The cells can have some anisonucleosis. There may be inflammatory cells associated with it. I pick this example as not necessarily the most classic example of schwannoma, but rather a clue that when you see a population of cells that are both spindle and epithelioid, think about the possibility of schwannoma. As a complete aside, if you're FNAing something like near the pancreas or somewhere around there, you can think about a GIST, because that can sometimes have a very similar biphasic sort of appearance on FNA. Here's something maybe a little bit more classic with more of a spindled cell population. There's some inflammatory cells in there. So it's not necessarily a home run all the time on schwannoma, but if you start to think about it, you think about a primarily spindle cell population. If you're unable to confirm that any further, it's likely to be a schwannoma, and clinicians like to have differential diagnoses or a prime diagnoses along with your Milan system category. So that's something you can say of benign neoplasm. It's a bland spindle cell proliferation, most likely a schwannoma. So SUMP is my favorite category. It's not a favorite category of a lot of clinicians, but there's a way you can help them if they don't like the SUMP category. They like it if you can give a differential diagnosis. So SUMP is your classic pattern recognition. So we're going to go through some pattern recognitions for how you can come up with a differential diagnosis and not just throw something into SUMP. You call it SUMP, you can explain what sort of pattern you're seeing, and then you can give a differential diagnosis for that pattern. If you truly are not certain whether something is malignant or benign, you're really on the fence both ways, you can list a differential diagnosis that includes both a malignant thing and a benign thing. That way the clinician understands that you truly don't know. If you can favor something, you can say, this seems most likely to be this, but you can't exclude these other things as well. So notes are very helpful when you're giving a SUMP category diagnosis to the clinician. Certainly, if you have a tumor board or you're talking to them directly on the phone about a lot of these cases, then you don't have to necessarily have a note if you're going to talk to them about it anyway, but communication is important. So here are some generic categories. What sort of things do we see that we put into SUMP? So we're getting away, you can work, some people they think about histology and they work back to cytology. So they think, what could this possibly be? But we're going to look at the cytology and see what is the pattern. And so this is sort of as far as we can go. Okay, so can we call something more generically? If you step back, we can't give a definitive diagnosis. We generically call it a cellular basaloid neoplasm, okay, or a cellular oncocytic neoplasm, or a neoplasm with clear cell features. Okay, so these are categories of patterns that we can put into the SUMP diagnosis. What are some examples of these things? So, for example, you see a basaloid neoplasm. It has fibrillary matrix, but you're not entirely sure it's a pleomorphic adenoma. Maybe there's some areas that are predominantly globular. Maybe it's very cellular in some areas. Maybe one area looks like pleomorphic adenoma, but other areas not so much. Okay, so you favor it's a pleomorphic adenoma, but you're not entirely sure. You're worried it could be another basal cell, basaloid neoplasm. So your differential could include a cellular PA. So this is what we like to say, in cytology. It's a pleomorphic adenoma, but it's very cellular. There's not a lot of matrix material. I'm explaining why I can't just call it a pleomorphic adenoma. Could it be an epithelial myoepithelial carcinoma or a basal cell adenoma / adenocarcinoma? I have young children and I'm at home, so you may hear either happy sounds or angry sounds, so I apologize for that. So here's another example of a basaloid neoplasm with fibrillary matrix. So here you see basaloid cells. It's fairly cellular, and then the material is somewhat fibrillary. Maybe it's a little bit more myxoid or mucinous here. Again, the odds are these things are going to end up being a pleomorphic adenoma, but the fibrillary matrix is not well developed. So you can have the same sort of differential diagnosis. It's a little bit less classic in this case. A cellular basaloid neoplasm. So here again, you have your basaloid cells. It's very cellular, and you have a little bit of a clue that there's some matrix material, okay? So we really need histology to tell us whether this is an invasive process or not an invasive process. This could still be a cellular pleomorphic adenoma, but now we're starting to deal with things with this thin hyaline matrix material that could be more associated with basal cell adenoma, adenocarcinoma. Can't completely exclude an adenoid cystic carcinoma in some of these entities here. So I appreciate that these are all malignant processes. So if you're unsure, again, always throw in that key term, cellular pleomorphic adenoma, can be helpful to tell the clinician you're considering a potentially a benign neoplasm. So beautiful picture, streaming sheets of basaloid cells. You have the hyaline matrix material, just like in the last example. So this is just another example of the previous of another pattern. So these are not the same case. These are two different cases I found that show this particular pattern. Okay, a basaloid neoplasm with scant matrix material, and you're starting to deal again with similar sort of entities. It could still be a cellular pleomorphic adenoma where you simply don't have the matrix material. But again, now you're starting to deal with things that adenoid cystic carcinoma, etc. Here's again, scant matrix material, a basaloid group of cells. In this case, you have kind of more of a fibroinflammatory background here, actually, that's not actually strictly matrix material. Okay, another option besides cellular basaloid neoplasm would be a cellular oncocytic neoplasm. So you can have a cellular oncocytic neoplasm with a mucinous background. So here you have a population of oncocytes. They're not in the normal configuration of the grape-like architecture of normal salivary tissue. So you'd want to have enough cellularity of this to be certain that it's a neoplasm. This is just one field, but it's cellular. It has atypical architecture, so it's not strictly non-neoplastic, it's neoplastic. And then you have this sort of mucinous or myxoid background. And so this could be anything ranging from a mucoepidermoid carcinoma that's an oncocytic variant that produces oncocytic cells, or a Warthin tumor with mucinous metaplasia, which was discussed in previous lectures. So it's great putting it all together. Now, you've just heard about all these different pitfalls and how SUMP now captures the possibility that this could be a benign thing, but also potentially there's a chance that it's malignant. Cellular oncocytic neoplasm with granular or vacuolated cytoplasm. So this is a fragment of these cells that have abundant cytoplasm. It's not the normal grape-like architecture. Certainly you can have some sort of metaplasia that disrupts the grape-like architecture in a non-neoplastic process. So you'd want to have a cellular population. This would have to be a cellular oncocytic neoplasm among the whole specimen, throughout the whole specimen. But then the differential could be actinic cell carcinoma, secretory carcinoma, or a metastatic renal cell carcinoma, for instance. A cellular oncocytic neoplasm with non-specific features. And so this is just a bunch of oncocytes. So this could be an oncocytoma or potentially a myoepithelioma. And then here, again, non-specific features, you see a cellular population, they're oncocytes, they're not in normal grape-like architecture. Again, this is just one field, but you look through the specimen and ensure that it's a cellular population that you feel is neoplastic with the same differential diagnosis. Another example, this could at initial view look like that there are grape-like structures, but in fact, you look more closely, you see that these are more, it's more of a trabecular growth pattern than a normal grape-like architecture with an acinar tissue. And so this is an example of a cellular oncocytic neoplasm. Now, the Milan system doesn't use this category cellular myoepithelial neoplasm, but I find it to be somewhat useful. So you may see a predominance of myoepithelial cells or spindle cells in the background. It doesn't really fit into those other categories. And so you may, again, be descriptive, it's under sump as a cellular myoepithelial neoplasm, where this could be a pleomorphic adenoma or a myoepithelioma, for instance. Another example here, the cells are predominantly spindled. They look like they're myoepithelial cells. You look at the whole specimen, it looks cellular, it looks neoplastic, but you can't be absolutely sure it's not something like a myoepithelial carcinoma, but most likely probably something benign. So these other two categories, suspicious for malignancy and malignancy, I won't go into in great detail. Suspicious for malignancy is a category for FNA specimens that show features that are highly suggestive, but not unequivocal for malignancy. So this is really a hard category to define. This is something where you are really using your experience as a cytopathologist in your impression of the case. You feel like it probably is malignant, but you're not up to that 95%, 99% certainty. You're more at that, again, 60% according to what the recommendations are, 60 to 70%, maybe even more, depending on what the surgeon's going to do at your institution, certainty. And so the FNA report, according to the Milan system, should state which type of malignant tumor is suspected or provide a differential diagnosis. So this is emphasized in the Milan system for suspicious category, but I just want to emphasize again that I think this is important for when you call something SUMP as well, not just suspicious. So again, the majority of specimens in this category will be high-grade carcinoma on follow-up. So these may be markedly atypical cells with a poor preparation, poor preservation of obscuring elements, or limited cytologic features for malignant neoplasm, or suspicious cytologic features in a subset of cells admixed with features of benign salivary gland lesions. So suggesting that it wasn't really sampled completely. So just an example, you have something that has pleomorphism, anesonucleosis, it's disorganized, but maybe this is the only fragment you have, or maybe you have some more fragments of this and you feel it's malignant, but you really can't be absolutely sure. You really don't feel confident. Maybe it has to do with your experience level. So it's sort of a very difficult category to define. Now, the malignant category is one where you either can definitively identify something. Maybe you have ancillary studies. Maybe it's a classic mucoepidermoid carcinoma. Maybe it's a classic actinic cell carcinoma. And these are things that you've had lectures on already. So I'm not going into specific examples of all these malignant processes. So either you can definitively diagnose a malignant lesion specifically, or just cytomorphologically, even though you can't classify something, you know it's malignant. You don't know exactly what it will be. Maybe you don't have a cell block. Maybe you don't have other material to work with, but you're sure it's malignant. You just can't classify it. The Milan system recommends that you should attempt to subclassify it as much as possible and even grade it. I think this can be a little bit challenging. I think if you can call something malignant, you should feel happy for yourself, but certainly if you feel like you can grade it, or if you feel like you can give a differential or a specific diagnosis, that's important. And something other to consider is, some of these other reporting systems like Paris, for instance, have an other category for malignancies that are metastases, etc. But the Milan system, these other malignancies are included in the malignant category. But of course, you would want to indicate that in a note. If you think it's a lymphoma, don't just say malignant. You say something more. You say you're diagnosing a lymphoma. It's not a primary salivary gland neoplasm. So just an example, something that you may not know definitively what this is. It could be any sort of high-grade process, but certainly are using our impression as cytomorphologists. We see that these are pleomorphic cells with a lot of anesonucleosis disorganization. And it, more than just this field, this is repeated. It's a very cellular process where you can be certain that this is a malignancy. So those are sort of the categories and the ways to use the Milan system. And the Milan system has been out for some time now. The book, I think, was published in 2018. And there have been a lot of studies of how the Milan system performs. And so that's beyond what I can really cover in this lecture. However, this was one of the larger meta-analysis and review of published literature by Dr. Baloch. And this table summarizes many different institutions. And the best way to read this table is to look at the performance from top down. So for instance, if something was called SUMP, what are the percentages that were malignant? Here, 30% were malignant and 61% were benign. And so this actually falls into what they predicted what SUMP would have. They thought that 30% of SUMPs would be malignant on follow-up. And so it seems like things are following what the categories were intended to predict. I put this statement in this regards to sensitivity and specificity. So it's always hard to calculate performance. I mean, there are many ways to calculate performance, but if you only look at cases where FNA was definitively diagnostic of a neoplasm or malignancy, right? So either you were sure it's a neoplasm, so that includes SUMP, or you're certain it's malignancy, that includes only the malignant category, you see that the sensitivity and specificity for neoplasm are very high, 97% sensitivity, 95% specificity for neoplasm. For definitive diagnosis of malignancy, specificity very high, 98%. So we're pretty good at that. Sensitivity, 80%. But that's okay, because we know that many of these cases, you just simply can't diagnose malignancy. And so this doesn't include necessarily SUMP, right? So these might have been called neoplasm and they still were triaged properly. Maybe patient has to go back for a neck dissection depending on what the initial surgery was. So we have a special issue coming out on atypia in cytology, and one of my colleagues who's a head and neck surgeon always wants to talk to me about Milan, and he doesn't like Milan. It doesn't mean I don't think people should use Milan. I think it's just that the clinicians sometimes need to understand Milan. They aren't happy if a pathologist puts a category like SUMP and doesn't include some sort of differential diagnosis. They really want to know what you're thinking. And so this is just a brief clinical commentary that you can read if you like. It just came out and is online, but it's really just to remind me to remind you that that clinicians really find it helpful to give a differential diagnosis. And it's important to talk to clinicians when you're implementing these systems so they know what to expect. And I think that many people who are experienced cytopathologists, salivary gland cytopathology, have used similar terminology and diagnoses and wording, that it's not hard to translate what you've already been doing into using the Milan system. So we have a little bit of time, so I just want to show a few cases that I think are interesting, or some additional things that weren't put into this initial lecture. I wasn't sure I would have enough time, but I think I have about 10 minutes. So I just want to use that and show you some interesting cases. So this is an FNA of a parotid, and you see here, you see predominantly population of spindle cells. They're very discohesive. They have a fair amount of cytoplasm actually, and the cells don't have a lot of anesonucleosis. The chromatin pattern is relatively bland, and they're in this background of kind of this myxoid or proteinaceous type material. And so what this is a case of, you can see there's some inflammatory cells too. And so, it's very discohesive. The schwannoma that I showed you, there's some fragments that are cohesive. And these cells are really this kind of plasmacytoid appearance. So this is an example of nodular fasciitis, which I think is, I like to show in almost all of my cytopathology lectures when I can, when it's appropriate, especially in the head and neck, because it's such a huge pitfall. These cells definitely look neoplastic and often look malignant. And so we're often looking at this can be very cellular. And so this is a classic example of something where a process where a patient, may or may not necessarily need to have this removed, may have something that's kind of a more severe diagnosis given. Here's another example where the cells are embedded in this matrix material. So they're kind of randomly embedded in the matrix material. You can kind of appreciate, again, they have kind of plasmacytoid cells. They're spindled, they're plump, they have a lot of cytoplasm. So in this sort of pattern, always consider the possibility of nodular fasciitis or having this in your differential diagnosis. Here's an example of a case that was called Wharton tumor. And looking at the slides, we did a review of Wharton tumors retrospectively, and we saw, okay, well, why did people call this a Wharton tumor? Well, they saw groups of cells that had a lot of cytoplasm that looked granular. You might be able to appreciate that this is not homogeneous cytoplasm. This may be granular here, but here it's a little bit more magenta colored, more homogeneous, might suggest something to you. But in other passes, this FNA sample kind of maybe something more cystic. So there was this maybe papillary-like fragment that you could argue looks somewhat oncocytic. And there's a lot of granular debris in the background. There's also mixed inflammation. However, the mixed inflammation is not strictly lymphocytes. It's also a lot of acute inflammatory cells. And so this could be represented in inflamed cyst contents. The nature of the cyst, unclear. Is it a Wharton tumor? Is it not? The person who looked at this specimen thought this was a Wharton tumor. But retrospectively, when you look at things a little bit more closely and see other things, you saw something that this is not a crystalloid. This is actually thick mucin. And on the Pap stain preparation, you see that there's actually some cells that have very light colored, likely possibly mucinous material in it. What was mentioned in the last lecture, of course, when pitfall is Wharton tumor with mucinous metaplasia, and certainly that's important. But if you're considering a differential between mucoepidermoid carcinoma and Wharton tumor with mucinous metaplasia, that's where you're going into the sum category with those two differential diagnoses. And so this actually ended up being a mucoepidermoid carcinoma on follow-up. Here's another interesting case. This is a very bizarre case. So this was a case that was called Wharton tumor. This case had a lot of polymorphous lymphocytes in the background, lots of them actually, and there was very few oncocytic cells. You see these very granular cells, very bland chromatin, bland nuclei, not really in the grape-like architecture, but it's a very small sample. Why was this called Wharton tumor besides the lymphocytes? Well, I think that someone thought maybe this group of lymphocytes here was actually a fragment of oncocytic cells. At least I'm guessing what they thought retrospectively. These are just lymphocytes that are not well preserved or stained, that are clustering together artifactually. Maybe this is mostly just a lymph node. Okay, I mean, that's always a possibility if you don't really have a lot of true oncocytic cells. Beautiful oncocytic cells. These were the very few cells that I could find in the whole specimen that predominantly had polymorphous lymphocytes. And so when this lesion was removed, it was actually found to be a lymph node with salivary tissue, with this inclusion of salivary tissue inside of it that had oncocytic change. And it seemed that this FNA was able to sample some of this tissue, but it was really just a lymph node. It was not a Wharton tumor. So Wharton tumor, again, just to reemphasize, I mean, because the Milan system, this is something that we theoretically can hang our hat on. We can say it's a Wharton tumor, make a definitive diagnosis. Always, my recommendation is to always have the oncocytic papillary fragments that are there, not just rarely, and that you do have, again, the granular debris and polymorphous lymphocytes. You want to have all three of those things in good portions, I think, to make the diagnosis. Otherwise, be a little bit cautious and think about what else you could be dealing with. It could be actually something non-neoplastic, which I'll show you as well, in which case you may be going into an AUS category rather than some. So we did do a retrospective study. This is unpublished data, but you can see that we divided cases that were called Wharton tumor on FNA. either definitively diagnosed of Werthin tumor or things that were Werthin tumor was favored but not definitively diagnosed. And when things were definitively diagnosed with Werthin tumor, you can see that 85% of the time it was a Werthin tumor, but 15% of the time, which is sizable, it actually was not. And some of the things that were pitfalls were actinic cell carcinoma and obstructive sialadenitis. These were two times each. And so, you're dealing with something that's malignancy, actinic cell carcinoma. You're doing something that's not a neoplasm at all. So Werthin tumor can be very challenging. And so it'd be an instance where, you might go up to SUMP because maybe it is something malignant, be cautious. Or if you're not sure it's a Werthin tumor, maybe it could be something non-neoplastic. You might be going to AUS to include non-neoplastic processes. Of things that were not definitively diagnosed of Werthin tumor, so we're hedging a little bit, and this is before the Milan system was being used at our institution. 20% of cases were other histologic diagnoses. And you can see some other things seen. Again, another actinic cell carcinoma, oncocytoma, mucoepidermoid carcinoma, cellular PA. So there's a lot of these sort of things. Something that is important to keep in mind is oncocytosis, or more specifically, nodular oncocytic hyperplasia, which technically is a non-neoplastic process, can be FNA'd and is often called in oncocytic neoplasm. So this often gets into the SUMP category, okay? And so this is a situation where something that's called SUMP ends up being technically non-neoplastic on resection. It's been shown that it can be very difficult to identify this process on FNA. And so it's appropriate, it's okay. And Milan system says it's okay if you call something SUMP and it ends up being this entity. That's a known pitfall. Everyone should understand that concept, because if you can't, otherwise you would not be able to call any cellular oncocytic process a neoplasm. You'd be calling it all AUS, and that would not be very helpful. I won't go into this in great detail, but you can see that this is just some examples that we looked at retrospectively, the authors looked at retrospectively of when this nodular oncocytic hyperplasia was the result on surgical pathology, what the fine needle aspiration called it. And you can see that back before the Milan system, a lot of these atypicals might have sort of been in the SUMP category, possible oncocytic neoplasm, or consistent with oncocytoma, which would have been in the benign neoplasm category. And so with that, I actually want to stay on task. So I'll just finish up with one more case, and then I'll go to the summary. So this is an illustrative case that we got as a confirming consult case. It was seen and diagnosed at an outside institution. This shows that there's a lot of material in the background. We don't know what it is. It could be generically kind of a proteinaceous material. Maybe it's a very thin myxoid or mucinous material. It was interpreted by the outside pathologist as being mucinous. They then saw what I would describe as kind of this basaloid population of cells, irregular fragment, and it was adjacent, or what they thought was embedded in fat. The interpretation of the outside is that this meant that this was an infiltrative process that was infiltrating fat tissue. My comment about that would be that cytology is not something where we should be trying to determine whether something's invasive or not. And so just because something is adjacent to adipose tissue, I would still be a little bit cautious about that. And so we held off a little bit. This was described as being a malignant process, but we were sort of seeing what looked to be a basaloid neoplasm. Just some other examples. Here you can actually appreciate now in the background, there seems to be some material that's a little bit more fibrillary. So that suggested the possibility of a pleomorphic adenoma. I think the outside pathologist also felt that this was possibly at least partially a pleomorphic adenoma, but it had undergone transformation into a carcinoma XPA. So it had components that were malignant that were invading the adipose tissue, as well as the traditional pleomorphic adenoma areas. The outside pathologist performed a Musa-Carmin stain and showed that there was positivity in this myxoid material in the background. And they interpret that as being transformation into a mucinous carcinoma. Of course, one pitfall is that pleomorphic adenoma matrix sometimes contains mucinous-like material that can stain positively for mucicarmine. And if you were to make this a grayscale image and imagine it as a pap stain or a Dipquik stain, you could imagine that this looks like a classic pleomorphic adenoma with the spindle cells embedded in the matrix material. So while we favored that this was a pleomorphic adenoma with cellular areas that look basaloid, we ultimately classified it at our own institution as a SUMP, as in we thought that this was a basaloid neoplasm, but we favored a cellular pleomorphic adenoma. It turns out that this ended up being a pleomorphic adenoma, but the patient was spared a more aggressive surgery based on that. So that's one way that we utilize the categories. So out of interest of time, I'm just going to jump to the summary, and happy to have some time for discussion and questions. So in summary, the Milan system divides categories by determining whether a certain neoplasm exists and whether you are uncertain or certain whether that neoplasm is benign or malignant. If it's indeterminate for neoplasia, the AUS category is used. When it's indeterminate for malignancy, SUMP or suspicious for malignancy are used. Neoplasm benign is used for identifiable benign neoplasms. And I mean, I've said this 5 times, but a differential diagnosis should be provided when a definitive diagnosis cannot be provided. Finally, identification of neoplastic cell morphology can aid in generating a differential diagnosis. So we show those patterns, and those patterns can help you give a differential diagnosis. So once you show the pattern, you don't think about, oh, what 3 things do I need to list, or what 2 things do I need to list? You have the pattern, and you can think about, okay, that's the pattern. These are the things that I can list as a differential diagnosis. And just as another note, as you can see from the previous lectures, as more testing in IHC has been developed, we're able to now make more definitive diagnosis on cytology, especially if there's stainable material in the cell block, to be more comfortable with the definitive diagnosis of some of these entities. Whereas prior to just recent years, this really wasn't feasible. So with that, I'm going to end, and I really thank you for your attention. I thank you for having me. I wish I could be there, and I think this is a wonderful session for you all, and I'm happy to take questions or discuss some of these topics. Thank you.
Thank you, sir. Thank you so much for an absolutely marvelous presentation. It was really a pleasure listening to you. So we do have several comments and questions, 2 or 3 of questions, I guess. So Dr. Nadeem tells us it's a wonderful presentation, Dr. Chris. And he asks, which lesion in your experience is most difficult to categorize?
So I think you may appreciate that I was harping a lot on Borthen tumor. I think that's something that in recent years I feel like when all the classic features are there, I'm comfortable. But I'm a little bit more cautious in recent years. I think that another entity that can be very challenging, and I didn't have a chance to show the case, is something that is basically pleomorphic adenoma. When all the classic features are there, it's fine. But I think what I'm trying to say is it's adenoid cystic carcinoma. So pleomorphic adenoma can often have a predominant growth pattern where it forms these globules and can mimic, if the FNA is predominantly of that area, what you would classically see as an adenoid cystic carcinoma in a textbook. And so because salivary gland FNAs are relatively uncommon, I mean, I love them, I wish I could have more, it takes a while to get a lot of experience with these. And so you may be dealing with someone 5 years out of training, 4 years out of training, and then you see this, you think this is an adenoid cystic carcinoma. It's just like the picture says, but then it's not, it's a pleomorphic adenoma. And so I'm very, 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 very cautious. I'm using cytomorphology alone for diagnosing adenoid cystic carcinoma. And I would, before I do that, I would always show someone else.
All right. Thank you, sir. Sir, another question from Dr. Nadeem again. With increasing usage of molecular technology, so do you think that Milan system needs upgradation?
Does it need an update?
Yes, sir. With the increasing use of molecular technology today, he wants to know whether it needs an upgradation according to your opinion. Yes,
and so they are working on a 2nd edition. I believe that there's been a release of an initial survey, And because it's an international system, I would encourage anyone with interest in salivary gland cytopathology to participate in the survey. But you're completely right, is that the molecular is moving so fast, and the molecular was there before. But with cytology, we're dealing mostly with molecular and ancillary testing on very small specimens. And so now that I think sometimes the IHC is very helpful. And so with some of these new markers, that's definitely, I think, one of the priorities for the second edition.
Okay, thank you so much, sir. So Dr. Indu has a question, a very interesting one. So she asks you whether you are an advocate or a critic of the Milan system.
So I'm an advocate. I think that the Milan system does get a little bit more criticism in general than the well-established systems, and even Paris, it gets a little bit more criticism. We've done surveys in the United States of pathologists, and the uptake of the Milan system is lagging a little bit behind Paris. The reason I like the Milan system is because I think it's more for us, the pathologists. It really can get you out of trouble when you have not yet gained enough experience to know how to formulate a diagnosis or how to formulate a differential diagnosis. I think it's very confusing to have 100 different salivary gland entities that you can recognize on histology, and then you go to cytology and you're trying to figure out, well, what matches up to each entity. And so it's kind of framework. It's identify the pattern. Well, first, is it neoplastic or not? Then identify the pattern. And then if you don't feel comfortable going any further, you don't have to. Versus, I think, trying to learn about the Milan system before the Milan system book, you would pull out a book and try to look at these things, and it'd be an atlas or something like, this is what adenoid cystic looks like. This is what Wharton tumor looks like. And that can be very misleading to think that something, just because you see something that looks like in a textbook, that's what you can call it on the FNA alone.
Right. Absolutely, sir. Thank you, sir. So Dr. Mrinmay Kumar Malik, he asks you, what are the lesions which you come across most often as false suspicious after histopathology following diagnosis of suspicious for malignancy on FNA? So on FNA, you're getting a suspicious for malignancy? No, actually, yes. And then on histopathology, it's actually false. It turns out to be falsely that. What are those lesions mostly that you encounter?
So we haven't done a retrospective study, and in my personal experience, I utilize that category very, very rarely. I think I've done it once, and I forget what it was, but it was malignant. So I don't have enough experience to say what the pitfalls would be for that one. I tend to be a little bit of a little bit more of a sump person, and trying to get suspicious. In our institution, when we call something suspicious, we're usually we like to have like a very high rate of follow-up malignancy.
Okay, sir. So he has another question for you. Dr. Malik tells us, do you grade adenoid cystic carcinomas on cytology? And what is the management protocol if you just call a tumor as adenoid cystic carcinoma on cytology? So first one is, do you grade adenoid cystic on cytology, sir?
No, I don't. I mean, unless it's something that's just really ugly. I mean, if it's something that looks really ugly, like that last example I showed you, which was not then I think it's very challenging to grade them on cytology. I think it's very hard to diagnose them on cytology just because there's always that pitfall of a cellular PA. So I tend not to make the diagnosis that frequently. And so that's straight out on cytology.
All right. And so if you call a tumor adenoid cystic on cytology, what is the management protocol in your institute, sir? That is what his second part of the question was, Dr. Malik's question.
So I mean, it can vary. I think it depends on the clinician a lot of times. So at our institution, what I've seen is, I think in the cases that I've seen, a lot of times it'll start out with let's say it's in the parotid. So it's a little bit, unusual. Say if they do a parotidectomy with a frozen section, if they can, because I think that they're not used to seeing that diagnosis on cytology, and so when they see it, I think they are a little bit more cautious and want to know what's really going on here.
Fair enough, sir. So he concludes by saying that it's an enlightening talk. He also appreciates Dr. Anchal's talk. And Dr. Santosh Kumar Mondol, he has a question for you, sir. Has it been accepted by all pathologists worldwide? The Milan system, he means. That has it been accepted by all the pathologists worldwide? He wants to know.
Yeah, it definitely has not been. It's not to say that people have given it a chance and rejected it. I think it's just one of those things that it hasn't reached everywhere yet. People haven't necessarily seen a reason to switch to it. And I haven't seen a survey of worldwide. Okay, there's a lot of publications in many different countries that show that many different countries are using the Milan system.
Right.
But we know that even in the United States, the take up is not all laboratories. It's maybe half of laboratories or less, you know, and so things take time. Usually by the time a second edition comes out, it's a little more solidified. People that have trained at academic centers have used it and they're used to seeing it. And so it takes time for this to sort of go through. But I will say that the Paris system and the Milan system, as opposed to the Bethesda system, where it was very North American centric initially, trying to jumpstart and include more international folks in the beginning and really encourage going and people talking internationally and serving international audience really jumpstarts the use of these things internationally rather than waiting for it to kind of grow in North America first and then spread.
Right, sir. Right. So Dr. Anchal Kakkar really appreciates your presentation. Great presentation and fabulous cases, Dr. Chris. And sir, okay, Dr. Mrinmay Kumar Malik, he has one last question for you, sir. How much do you trust MIB in differentiating adenoid cystic from basaloid if it is positive?
So I am an advocate of using these stains in these ancillary tests, but we typically have not really grown into them yet in our laboratory. Part of the reason is historically we're a very cytomorphological division, and so we have not really adapted these stains quite yet to the point where we use them regularly, and so that's another reason I think where we're really hitting these Milan system categories based on a pattern-based approach.
Okay, sir. Okay, thank you so much. Sir, I'll just read out a few more comments just to tell you how much we appreciate this. Sir, Dr. Mamata Guho Mallik Sinha, she tells you that, thank you, Dr. Chris, excellent presentation. All three speakers enriched us. Thank you all. Dr. Bhatia tells us, thank you for an excellent presentation. Sir, Shuman Ghosh, Dr. Chris, very well covered topic. Dr. Polash Kumar Mondol, excellent lectures by Dr. Mrinmay Mallik, Dr. Anchal Kakkar, another such is going on. And so Dr. Debashish Mukhopadhyay presentation was great. And we have Shopun Shorkar who tells us that the platform design, look and feel is really marvelous. Thank you so much. And Riham Mahendru has asked us if it is possible to watch this later. We're very sorry, but no recording is available for future convenient viewing. I think, yes, and I did read out Dr. Nadeem's wonderful presentation, Dr. Chris. Thank you so much, sir. I think that is all for, okay, Dr. Bidut Kumar Krishna Goswami has also told you, excellent presentation. Thank you so much, sir. Thank you.
Thank you so much. And all the participants, don't hesitate to, shoot me an email or whatever if you have any questions.
Oh, sir, that is so kind. Thank you so much. Thank you. Sir, I would conclude by saying that I know I speak for everyone here when I say that it is difficult to express in words how grateful we feel right now. It was wonderful to have you here, sir. You have made our CME so much more special. On behalf of West Bengal Cytology Society, I extend my heartfelt gratitude. Thank you so much, sir. Thank you once again.
Thank you.
So that brings us to the last session of the day, a very interesting one. We have a wonderful panel discussion lined up for you. And to moderate this session, may I call upon Dr. Saurabh Bhaumik, consultant histopathologist and laboratory head, Fortis Hospital, Kolkata. His special interests are oncopathology, GI pathology, and cytopathology. Dr. Saurabh Bhaumik, please take over.
Thank you very much. Am I audible?
Yes, doctor, you are audible.
Let me share my screen.
Yeah, sure, sir.
Is it there?
Yes, Doctor. It's there.
Okay. A very good evening to you all, and hope you all are doing fine. So for this evening, we have a very interesting topic, that is salivary gland lesions, too hard to swallow. So the salivary gland tumors are actually well known for its diversities. We have seen in the previous sessions, there are very much morphological diversities, and there are very much overlapping morphological features, and that's why we becomes very much confused sometimes. So, for to give our diagnosis, and for that, we are fortunate enough that we commonly see the benign ones, that is the pleomorphic adenoma or adenocytic carcinoma or Burden's tumor. But that, as the previous speaker said, that is also very much confusing at many times. So if we look at the incidence of the salivary gland lesions are about 15 cases per 1 lakh populations annually. Most of them are benign, that is 75 to 85%. And the malignancies are comparatively less, that is less than 0.5% of all cancers. And so let us consider the challenges. What do we commonly see by dealing with the cytomorphology of the salivary glands? There are very much of morphological variations, and most of the malignancies are low grade. So we cannot differentiate by only the cytolytic pain many times. And we can diagnose high grade malignancies, but we feel difficult to segregate them from one to another. And there are many more newer entities adding up in the chart, and similar cytolytic constituents are shared by many of the entities. So I feel very much difficulty how to differentiate. So in this background, let's go to our discussion. There is a salivary gland lesions, too hard to swallow. For this, we have some eminent experts with us to discuss over this topic. Let me welcome Professor Bidut Krishna Goswami, and she is a head and professor of the Department of Pathology of the North Bengal Medical College. And he is also my teacher and mentor from my PG days. And we have Professor Colonel Dr. Jaswinder Kaur Bhatia, and she is the head of the Department of Pathology at the Command Hospital, Kolkata. We have Dr. Sravasti Roy, and Madam is the lab in charge of Swaraj Gupta Cancer Center and Research Institute. And she is also the president of our very own Calcutta Association of Practicing Pathologists. And we also have Dr. Indu Arun, and she is a senior consultant Department of Pathology of Tata Medical Center, Kolkata. So without wasting time, let's go to the discussion, and we will go on a case-based manner so that it becomes much more interesting. And to the delegates and the faculties, and if you have any queries, please put the questions in the chat box, and we will take up the questions at the end of the session. So let's start our first case. It was a 59-year-old male who has a swelling in the left parotid region. The size of the swelling is pretty big. It is 5 by 4 centimeter, and it was stayed there for the 6 months. Lesion is non-tender. Seal was firm to hard. On CT scan, bone erosion was found. Aspirate was blood mixed. So FNSC was done. Let's look at the slides. So there is the smears are pretty cellular, and we can see some discoesive cells in fragment. And if we go to the higher power, we can see the cells are mostly basaloid in appearance and having a discoesive pattern of scant cytoplasm, inconspicuous nucleoli. So if we can summarize the findings, there are the basaloid epithelial cells predominates, and the matrix is scant or absent. Tumor cells are not very cohesive. Some are angulated nuclear contour, coarse chromatin, and irregular nucleoli are noted in some of the cells, and naked nuclei appearance of the individual tumor cells. So what can be the possible differentials here? So I'll go to Dr. Bhatia, ma'am. Ma'am, can you please tell what we should think in this kind of smears?
Good evening to all of you. Let's see. Could we have the next slide? Yeah. So
Yes.
finally, we are coming to a group of lesions which are cellular bacilloid neoplasms of the salivary glands. Now, here we are seeing groups of cells which are epithelial or biphasic epithelial or myoepithelial neoplasms. And thus comes the DD of a spectrum of these cells. These are basically pleomorphic adenomas, basal cell adenomas, low to intermediate grade carcinomas, basal cell adenocarcinomas, and adenoid cystic carcinomas. The basic component here is a relatively monotonous crowded group of ovoid epithelial cells or small basaloid cells with scant cytoplasm, round nuclei. And this distinction is dependent upon the presence or absence of a number of features. Next slide, please. They are the most heterogeneous group and the most difficult to describe and diagnose, as Dr. Chris has already mentioned that it's very difficult to take one feature and diagnose these lesions. So we will go step by step as to how to and dissect out as to how to come to a particular conclusion. Next slide.
Exactly, ma'am. It is a very pretty difficult area we are dealing with. And that's why we dispatched a report in a broad spectrum way. We describe the cells and background in the description, and we reported it as a basaloid neoplasm of salivary gland and asked for an urgent excision biopsy for categorization. So we are fortunate enough that we got the biopsy of the same patient, and on the histopathology, it was come out as adenoid cystic carcinoma, solid variant. There is a much lesser stromal fragment was there, as we have seen in the cytosmear. So there are very much of cytological mimickers in this group of tumors. So ma'am, can you help also how we can approach if we get such kind of basaloid cells in cytomorphosis salivary glands?
Let's go along, and as we go along the slides, let's try to diagnose these on the basis of the features which I have just mentioned. Next slide.
Sure, ma'am. Sure, ma'am.
Yeah, so the first one, as you see, this is a case of a pleomorphic adenoma. You can just, the minute you see the slide, you can identify this fibromyxoid kind of a stroma in the background, which is kind of a magenta colored, along with small clusters of cells here. You can see these small clusters of cells at a low part, and slightly higher part, you can see this material, which is fibrochondromyxoid. At a slightly higher part, you can identify these cells, plasmacytoid cells, and they are round cells with some amount of cytoplasm. The character of this fibromyxoid material or the magenta colored material is fibrillary. So if we can appreciate that, we are more or less going into the direction of pleomorphic adenoma, and you would see these cells which are showing some spindleish cells, which are better categorized on Pap stain. Go to the next slide, please. Yeah, here you can see this myoepithelial and this is the stroma here, and they are attached to the cells. So the matrix and the cells, they are closely associated with each other. So this would go in the direction of pleomorphic adenoma. So what I would say is that a fibrillary chondromyxoid ground substance, variable cellularity, you may just have very few cells or you may have more cells, myoepithelial cells, ovoid, plasmacytoid or spindle cells, abundant cytoplasm and regular ovoid nuclei with bland nuclear chromatin, smooth nuclear membrane, and spindle-shaped myoepithelial cells embedded in the stromal matrix. So a combination of these, that is the matrix, fibrillary matrix, the cells, the myoepithelial cells, which are closely associated with each other, give a diagnosis of pleomorphic adenoma, which was later confirmed on histopathological diagnosis. The next differential diagnosis which is commonly encountered is adenoid cystic carcinoma. Now let's just go on to the cytological features here. These are again cellular smears. You would see these large fragments, but if you see this kind of a material, you can see these rounded edges of the material. And let's go to the higher part, Dr. Saurabh. Yeah, here in these clusters, they show kind of a characterless or a little bit of cup. You can see a cup here, and these are the matrix along with cells. Now these cells have very scant cytoplasm. Here the cells have very scant cytoplasm. Some of the cells are showing nuclei which are angular. So let's recapitulate the features which we saw. Cellular smears, cells both single and clustered, hyaline spherical globules of varying sizes with adherent tumor cells, cellular tissue fragments with finger-like. We saw some finger-like cords or strands also, but they do not have the fibrillary nature. Multi-layered dense cell clusters, cup-shaped fragments, which we saw. The cells have scanty cytoplasm, a high NC ratio, nuclear molding and naked nuclei, and the cells are relatively uniform. Some of the cells showing round to oval hyperchromatic nuclei and presence of nucleoli. On histopathology, then this case was diagnosed as adenoid cystic conventional. Here, these are the same higher powers of the same. Adenoid cystic carcinoma is the second most common salivary gland malignancy and the most common malignancy that presents as a cellular basiloid neoplasm or FL. So the features which we see here, clustered sheets and trabeculae of basiloid epithelial cells associated with globules of matrix-like material that have an acellular punched out kind of, you'll see these punched out appearances and windows. In contrast to pleomorphic adenoma and basal cell adenoma, these are not embedded with, they're separated from these globules, and fibrillary type matrix is typically absent. Next slide, please. So the diagnostic clues here would be large globules. If you see them, you should be able to kind of give one diagnosis here with predominance of basiloid tumor cells. But if you don't see these globules, then all other benign and malignant salivary gland tumors of epithelial, myoepithelial differentiation, including pleomorphic adenoma, should be considered in the cytological diagnosis. Mind you, these hyaline stromal globules are not easy. I mean, just the minute you see these hyaline stromal globules, don't make a diagnosis of adenoid cystic carcinoma, because the distinction between basiloid neoplasm like basal cell adenoma, adenocarcinoma, many other entities can have these globules. Now, coming to pleomorphic adenoma. Here, at times, pleomorphic adenoma matrix can also take on a circumscribed appearance, which can mimic this material of adenoid cystic carcinoma. So therein you look for myoepithelial cells. So you basically kind of make a algorithm in which you see these different points and then you try to fit in. And if you, it's not just one factor that can give you a diagnosis. So you just inspect it carefully again. If you see myoepithelial cell, fibrillary stroma, and some other clues which can help you come to a diagnosis, then it goes towards the direction of pleomorphic adenoma. So a wide spectrum of findings that may complicate the diagnosis. When you have all the three features, typical cytological features, presence of fibrillary acellular matrix material, then sometimes the cellular variant of pleomorphic adenoma may just show a predominance of myoepithelial cell or basiloid cell without the or very less matrix material. And sometimes even sampling is very difficult and you may not get any cells or any material. So these are the pitfalls. The features which we can see in pleomorphic adenoma are cellular pleomorphic adenoma with very sparse matrix. Or sometimes even you can see adenoid cystic-like areas, but then you look for other clues. Cytological atypia and metaplastic cells. This is again very important. We must remember that you can see squamous cells, sebaceous cells, mucinous cells, oncocytic cells. So pleomorphic adenoma is one of the most difficult diagnoses to make and one of the most easy diagnosis to make on cytology. Yeah. So if you're seeing hyaline cell, the differential diagnosis would be plasmacytoma. Squamous cells, think of squamous cell carcinoma, mucoepidermoid carcinoma, mucus, again, goblet cells. Sometimes you will say it's mucin. Mucoepidermoid carcinoma should come in differential. Presence of oncocytes, rule out of organs, oncocytoma, sebaceous cells, sebaceous neoplasm, and hyaline globules. Again, go to adenoid cystic carcinoma or basal cell adenoma.
Excellent, ma'am.
So, basiloid epithelium predominates in solid variant. The first slide, which Dr. Saurav showed you, here we did not see much of matrix, neither did we see any globules. So, it's a very difficult diagnostic challenge. The tumor cells are less cohesive than cellular PA or basal cell adenoma, and cytoplasm may be so scant so that the cells, they look like, the nuclei look like naked nuclei appearance. Mitosis, necrosis is not observed. So herein what we see is a compact sheet-like and nested pattern of rounded basiloid cells which lack the obvious cribriform or tubular architecture. You see here, just show the next slide, please. Yeah, herein this is basically kind of a, you can see these cells are forming small nested or clustered kind of an appearance that may give a clue. And if we have it in mind, we can always think of a solid variant and then finally confirm it on histopathology. Basal cell adenoma is another one great mimicker, characterized by the presence of tightly cohesive. The cells are so cohesive, three-dimensional clusters, not much ATPR, cords of these cells. You'll see more of cylinders and less of globules with scant cytoplasm and uniform bland nuclei. Myoepithelial cells are scant or absent. Extracellular material may be present, but that is typically denser and less fibrillary than pleomorphic adenoma matrix. So we have aspirate, which shows a cellular basaloid aspirate. Think of these DDs, and with the cytonuclear features and stromal background characteristics, we can somehow come to a limited differential diagnosis. Pleomorphic adenoma showing planned ductal cells with plasmacytoid, epithelioid, and spindle cells, and a fibrillary metachromatic matrix. Adenoid cystic carcinoma with its globules. Stroma is less, a solid variant has less stroma, and this has sheet-like and nested pattern of cells. Adenoid cystic would show angulated hypochromatic cells, cylinders of hyaline stroma with globules. Basal cell adenoma again shows a polygenized stroma with interdigitating. The tumor cells are embedded in the matrix, and the cells are monomorphic and ovoid cells.
Excellent, ma'am. So,
yeah, what we do is basically kind of, it's a matrix or a jigsaw puzzle, which we try to fit in on cytomorphology, and then we kind of overcome these challenges in these cellular basaloid kind of neoplasms. Dr. Saurabh.
Thank you, ma'am. So, ma'am has very lucidly and extensively described the points which should we keep in mind while dealing with such kinds of basaloid neoplasms. And though we are very commonly find the pleomorphic adenoma or adenocystic carcinoma was relatively common to find in our regular practice, but they are very much confusing because of their different kinds of diversities and because different types of cellular components. So we have to look for the background stroma. We have to look for how the cells are looking, whether there is presence of myepithelial cells or not, the varieties of myepithelial cells, and by keeping in mind this point, we possibly might reach to the diagnosis of basaloid neoplasm. But also, in many cases, we can go to the exact categorization of the tumors, and that's why the Milan system concept has emerged. So let's go to our next case, that is case 2. Here, a 7-year-old boy presented with a firm, round, non-tender swelling, and it is pretty small in size, 2.5 by 2.5 centimeter in the preauricular region for the last 2 to 3 months, and which gradually increased in size since the last 2 weeks. And CCT showed the peripherally enhancing lesion with some hypodense region. And on this background, we did the FNAC of the patient, and here are the FNAC smears. And here also the smears are pretty cellular, and there is some trabecular and papillaroid architecture there, and the cells are a bit discohesive, and many single cells are lying in the background. And if we go to the higher power, the cells have moderate to voluminous amount of cytoplasm with some cytoplasmic vacuolations. We have round to ovoid nuclei and prominent distinct nucleoli in the paired state. The vacuolations are also very much prominent here. So, considering these features, what can be the possible differentials? Let me go to Dr. Indu. Ma'am, can you please help us? So, what might be the differentials that come in our mind considering these kind of cytological features? Dr. Indu.
Thank you, Dr. Saurabh, and good evening, everyone. Dr. Saurabh, can you go back to the previous slide?
Yeah, sure, ma'am. In the low power view, ma'am?
Yes. No, high power view.
Okay.
Next slide. Yeah. So, as Dr. Saurabh showed, the aspirate is highly cellular, and there is no doubt that this is a neoplasm because you are not seeing any normal ductal structures or isna structures, and you can see if you look at the cytologic details of this tumor, the cells have abundant granular cytoplasm and have multiple vacuoles, as he has already described, and they have uniform nuclei with fine chromatin and prominent small nucleoli. and the nuclei shows low-grade features. And as you can see, the pap stain smear, there are multiple vacuoles with some kind of secretion in it, and this could possibly be mucin. We cannot make out at this stage. So with these cytologic features in mind, we can report this tumor as best as salivary gland neoplasm, favor low grade. And if you are using a Milan system for reporting, you can classify this as salivary some category. This, as Dr. Chris has already described, that is salivary gland neoplasm of uncertain malignant potential, category 4. Yeah. So the differentials which I would consider in this case are the following. That is, one is secretory carcinoma, which can show all these cytologic features. Second differential would be cymogen granule poor acinic cell carcinoma, because I'm not seeing any definite cymogen granules. Then third differential would be a low-grade mucoepidermoid carcinoma, because we are seeing some secretions in the cytoplasm, which we do not know whether it is mucin or not. And the fourth differential would be oncocytic neoplasm, such as Warthin tumor or oncocytoma. Over
Fair
to
enough.
you.
Fair enough. So possibly we able to do cell block here. In the cell block, we got some sheets of cells in the dispersive manner. As ma'am has said, the cells have voluminous secretory cytoplasm, as also said in the cell block. They are regular nuclei, monomorphic, with distinct nucleoli. We also done immuno on the cell block, and we got ACE100 positivity. Mammoglobin was also positive, and DOG1 was negative. So by doing immunostains on the cell block sections, we came to a diagnosis of it's the case of secretory carcinoma, which was previously known as mammary analog secretory carcinoma. So there are various mimickers of the secretory carcinoma, as ma'am has already said. And this was the histopath pictures. Ma'am, can you just describe the histopath if you wish to?
Yes, so these tumors typically they are unencapsulated, and but they are usually circumscribed. And you can see that these tumors can show broad fronts of invasion into the extraglandular tissue, and perineural invasion can be seen, but lymphovascular invasion is not usually seen, showing that this is low-grade neoplasm.
So please help us to distinguish the secretory carcinoma from its mimickers. How we should go, how we should proceed to explore the
Can you go back
mimickers?
to the previous slide, please? I haven't finished.
Sure.
So this tumor show a variety of morphologic pattern, architectural patterns, such as microcystic pattern, papillary pattern, and solid pattern. As you can see in this high power view, this is showing the typical microcystic pattern with bubbly basophilic secretions within the cystic spaces. And these secretions are positive for the special stains for mucin, such as mucicarmine, Alcian blue, etc. And this may cause confusion with mucoepidermoid carcinoma. But you usually do not see other cell types which are seen in mucoepidermoid carcinoma. And these are low-grade tumors, so mitotic figures are usually not seen, and necrosis is not seen, unless there is a high-grade transformation which has been described in this entity. Next slide.
Excellent, ma'am. This is a very vivid description of how the possible histopathology can look. So, ma'am, please help us to how we can proceed to distinguish it from its cytological mimickers. That is, as you have mentioned, we should consider acinic cell carcinoma, mucoepidermoid carcinoma, and other oncocytic neoplasms. How we should proceed, ma'am?
Yeah, next slide, please. So I have put the two pictures of both acinic cell carcinoma and secretory carcinoma side by side for comparison. So if you look at the aspirate from an acinic cell carcinoma, you can see a monomorphic population of polygonal cells with abundant cytoplasm, and they have low nuclear to cytoplasmic ratio because of the abundant cytoplasm, and they have monomorphic nuclei without any nuclear atypia. And there are many stripped nuclei can be seen in the background. And when you look at the secretory carcinoma, you can see multiple vacuoles in the cytoplasm, which is not seen in the case of an ethnic cell carcinoma. Next slide, please. So here in this picture, you can better appreciate the basophilic zymogen granules in the cytoplasm of these cells, which are not seen in secretory carcinoma. Next slide. So this is a cell block preparation of ethnic cell carcinoma, where you can see acinar cells with dense basophilic granules, and you can also see these intercalated type of ductal cells without granules. Next slide. And these basophilic granules are positive for PAS with diastase, which are not seen in secretory carcinoma. Next slide. So in addition, ancillary test immunohistochemistry can help to differentiate ethnic cell carcinoma from secretory carcinoma. Ethnic cell carcinoma shows diffuse cytoplasmic membranous positivity for DOG1. Next slide. While DOG1 is negative in secretory carcinoma. And in addition, ethnic cell carcinomas are negative for GATA3, mammaglobin, and S100, which are positive in secretory carcinoma, as Dr. Saurav showed in the previous slides. Next slide. Next differential is mucoepidermoid carcinoma. Mucoepidermoid carcinoma, as I already mentioned, shows 3 cell types, that is epidermoid cells, intermediate cells, and mucous cells. In this picture, you can see mainly intermediate cells and some mucous cells. Next slide. So this is a higher power view where you can see the epidermoid cells as well as the intermediate cells and goblet-like mucous cells. And the typical cytoplasmic vacuolation which you see in secretory carcinoma is absent in mucoepidermoid carcinoma. Next slide. Oncocytic neoplasms such as Warthin tumor also comes in the differential, but these neoplasms have homogeneous eosinophilic cytoplasm and also lack the cytoplasmic vacuolation, which are prominent in secretory carcinoma. So this table depicts the most common immunoprofiles in salivary gland tumors with oncocytic features. Since secretory carcinoma come under the category of neoplasm with oncocytic features, these immunomarkers may be helpful in differentiating these tumors, which includes P63, P40, S100, mammaglobin, SOX10, DOG1, GATA3, and androgen receptor. So Warthin tumor or oncocytomas are positive for P63 while they are negative for other markers. Ethnic cell carcinoma is positive for SOX10 and DOG1 while they are negative for all other markers. Secretory carcinomas are positive for S100, mammaglobin, SOX10, and GATA3 while they are negative for DOG1 and P40. Mucoepidermoid carcinomas show diffuse positivity for P63 and P40. They may or may not show positivity for SOX10 and DOG1. While they are negative for all other markers. Salivary duct carcinomas, the low-grade ones, may come in the differential, and they are also positive for mammaglobin and GATA3, but they also show expression of androgen receptors, and they are negative for S100. So some other new markers which have been described as STAT5A and MUC4, which is found to be very specific for the diagnosis of secretory carcinoma. If there is a difficulty in the diagnosis of secretory carcinoma, if they do not show the typical cytologic features, one can go for a FISH study, cytogenetic study for 1215 translocation, which is diagnostic. The presence of this translocation is diagnostic of this entity, this translocation results in ETV6 NTRK3 fusion product. Next slide.
Nice. So thank you, ma'am. And it was a very nice description. So how we can differentiate between the entities where we find the features like secretory carcinoma, or it might be arsenic or Warthin, we should keep in mind and to differentiate those cases. Okay. Let's move on to another interesting case. And here, the patient was a 57-year-old female and who is a known patient of rheumatoid arthritis. And she had a slowly growing lesion in the left submandibular region for the last 6 months. Ultrasound shows a 3 × 3 centimeter cystic swelling in that region. And with this presentation, we did the FNA. The FNA spheres are pretty low cellularity. The background shows many small lymphocytes are there. And if we go to the higher power, we can see some polygonal to round cells having voluminous granular cytoplasm with monomorphic nuclei are there. So there is a low celluloid smears, predominantly lymphoid cells in the background, and they are mostly polymorphous lymphoid cells, and few aggregates and scattered population of cells having moderate amount of granular cytoplasm, looking like oncocytic cells. So what can be the possibilities? Let's go to Dr. Sravasti Roy, ma'am. Ma'am, please enumerate what might be the possibility, what we should think when we get such kinds of cytological pictures. This is
okay, thank you, sir.
Low cellular smear.
Good evening, everybody. Good evening, everybody. First of all, thank you to the organizers for A, organizing such a wonderful seminar, and B, allowing me to participate. Saurav, could you go back to the previous slides, the low part?
Sure.
Yeah, okay. So here you have a lesion which has yielded a kind of necrotic degenerate aspirate with a few epithelial cells, lymphocytes. Next slide, Saurav. Yeah, if you can see, there are 1 or 2 histiocytic cells out here. I can see them. Saurav, you can activate your pointer. And here there is this cluster of epithelial cells, which sort of you could think it has an oncocytic appearance. Yeah. So when you get this kind of appearance, or you get a salivary lesion, or commonly what we get is a lesion in the parotid, and you're getting a cystic aspirate. It could be mucoid, it maybe could be antral serosanguinous. So the differentials are basically maybe broadly categorized into 3. Number 1, non-neoplastic. Secondly, neoplastic benign with cystic degeneration, and neoplastic malignant with cystic degeneration. Now, since we have already discussed that malignancies form a very small component of salivary gland lesions, the first group that we need to look into are the non-neoplastic ones. So in this kind of smear, the first, the differentials that we need to consider: 1, retention cyst or a salivary duct cyst, a lymphoepithelial cyst, branchial cleft cyst, an epidermal cyst, and last but not the least, an inflammatory lesion. And to my young friends starting off in the practice, keep this inflammatory lesion, particularly in our country, keep it in mind that it could be inflammatory plus minus tuberculosis. Always keep a practical point of all of you starting off. Keep one smear aside. You might need to do a Ziehl-Nielsen, and you might be surprised at the results in quite a few cases. So a very, very practical thing, please keep it in mind. So these are the 5 non-neoplastic lesions. For neoplastic, you could have cystic degeneration in benign and malignant tumors. Again, a practical point with many patients going in for alternative therapies. Whether that's a controversial topic, but we'll be deceiving ourselves if we do not accept the fact that patients who have undergone some form of alternative therapy or generally land up with degenerative changes in their tumors at any body site, breast, parotid. So you keep those the chance of degenerative changes in neoplastic lesions in mind. Next, Saurav, go back to the next one. So these are our differentials. It could be a Warthin in a benign tumor. It could be degenerative change in a Warthin or a pleomorphic salivary adenoma. It could be degenerative changes in a mucoepidermoid or adenoid cystic. Importantly, it could be a metastatic carcinoma with degenerative changes. Next, please.
Thank you, ma'am. There is so much of differentials in this case which we can think, and this is really a difficult area in salivary gland cytopathology when you get such kind of cystic changes only, and without many clues what it might be.
And very importantly, sorry to interrupt, Saurav, we have to remember that we cannot really keep taking multiple aspirates.
Yeah, that's true.
There's only a certain number of multi-site aspirations that you can do.
And so ma'am has also correctly said, because of the alternative medicine, many such cases we found only such kind of cystic changes without the definite clue what it may be.
Exactly.
Okay. So in the considering the cytomorphology and presence of some granular cells which might be oncocyte, which we thought, we released the report as it's a cystic lesion, possibly as a salivary gland neoplasm, and Warthin's tumor need to be excluded. and we recommended for urgent excision biopsy of this case. So we got the biopsy specimen, and in the low power, we got a cystic space lined by some epithelial cells, and in the surrounding salivary gland zone, there is a destruction of the acini by dense infiltration of lymphocytes with conventional lymphoid follicles. When we go to the higher power, we find that there is infiltration of these small lymphocytes in the epithelial cells. It was in the duct epithelial cells and also in the cyst lining cells. So considering these histopathological pictures, we again go back to our FNA slides. So what we have missed in that slide. So after thorough searching, we found a single cluster in a slide where we find some epithelial cells there. There's the small cluster epithelial cells where lymphocytes have infiltrated. So considering the histo and cytomorphological pictures here, we diagnosed this case as a lymphoepithelial cyst of submandibular gland. So lymphoepithelial cyst is a slow-growing unilocular or multilocular lesion. It is commonly found in the head neck region and including the salivary glands. In the background, there might be some HIV infection or some autoimmune disease, including the Sjogren syndrome. And in the cytomorphology, we get mostly the polymorphous lymphoid background. And if we are fortunate enough, we might get that lymphocytes permeating this lining epithelial cells. And considering this cystic change, we have to rule out the other lesions of salivary gland where we might get some cystic lesions. So what might be the other possibilities there? So as ma'am has said, it might we can jot down few of the entities of the varied possibility it might be. It might be Bordin tumor, it might be branchial cleft cyst, or it might be low-grade mucoepidermal carcinoma also. So ma'am, can you please help us to differentiate between these entities?
So the speakers before have discussed this. Just to recapitulate, in a Bordin tumor, you are likely to get prominent oncocytes with dense granular cytoplasm, central nuclei, small nucleoli, and sheets of oncocytic cells in a honeycombing pattern, and mixed lymphoid cells in a dirty proteinaceous background. Whereas in lymphoepithelial cyst, you'll get a predominant polymorphous lymphoid background on a cystic matrix, and lymphocytes infiltrating the epithelial islands. So here you have these are typically Bordins. Yes, here you have the oncocytic cells. This is the lymphocytic background. You see, depending on your sampling, you could have a polymorphic lymphocytic background or you could have a monomorphic lymphocytic background. The moment it becomes monomorphic, again, you have to keep, if you haven't got those epithelial cells, you might want to keep a differential of lymphoproliferative in mind. Yeah. But this is generally characteristic. You get this. So differential diagnostic, if you get just lymphocytes and on the typical background, the differential is a lymphoepithelial cyst. You get atypical squamous cells or oncocytes. It could be a squamous cell carcinoma or even a salivary duct carcinoma with oncocytic or squamous cell changes. Granular cells, if you get in, keep a differential of acinic cell carcinoma in mind. As I said before, if the lymphocyte population in your smear is monomorphic, more immature, then keep the diagnosis of malignant lymphoma in mind. If the background shows metachromatic mucus, think mucoepidermal carcinoma, pleomorphic adenoma, adenoid cystic carcinoma. And if you get oncocytes, lymphocytes plus minus, but a cystic content, think of chronic sialadenitis, but chronic sialadenitis, generally the smears are uniformly hypocellular. Okay. Branchial cyst, squamous epithelial cells, abundant lymphocytes, and amorphous debris in the background. Like in this slide, you get these dispersed squamous cells. Again, if most of them are anucleate squames, again, keep the diagnosis of epidermal cyst in mind. Lymphoepithelial cell cyst, you'll get polymorphous lymphocytes infiltrating into the epithelial cell islands, and squamous cells may be found. Here you can see the lymphocytes sort of merged along with the epithelial cells. Okay, Saurabh, go ahead. Next, low-grade mucoepidermal carcinoma. They can be acellular or hypocellular smears. Extracellular mucin may be the predominant finding. Again, sampling. Look for epidermal cells, intermediate cells, and mucocytes, and lymphocytes may be present. Whereas again, a lymphoepithelial cyst, you'll get those polymorphous infiltrate and merging with epithelial cells. Next, Saurav. Here, a typical case, there's this dirty proteinaceous background with inflammatory cells, degenerate epithelial cells, this huge deposit of mucin out here, a few scattered inflammatory cells. Again, metachromatic mucin deposition out here. But then you get this cluster of cells with largely monomorphic nuclei and moderate vacuolated cytoplasm. Here again, you get these cells, and here columnar cells, here sort of vacuolated to faint cytoplasm. Next.
So, ma'am, thank you, ma'am. So we have seen so many of entities might be there in case of when we find the cystic lesions, and it is very much difficult for us when we get such kind of cystic aspirate. So possibly we all have some experience regarding this when we get some cystic change and cannot make out what it can be. Ma'am, can you share your experience in
Okay, I'll just, with the shortage of time, I'll just share two experiences with you. One was, this was a parotid SL, 8 ml serosanguinous fluid aspirated. That was all. And the smears were made from the aspirate, from the centrifuged aspirate, and this is all we got. Every slide just showed this degenerate cells, a few scattered inflammatory cells, a kind of vague proteinaceous background. And I had to sign it out as a degenerative cystic lesion and ask for a biopsy. And in fact, I did not have radiology to support me, so I said most likely from the parotid. And this turned out to be, it was a lesion with cystic and solid components, and this is what the solid component looked like. A typical pleomorphic adenoma. The solid component was unequivocally pleomorphic adenoma, but the cystic component, again, I don't remember because this was an old case. For whatever reason, whether it was iatrogenic cystic degeneration or de novo, I don't remember, but you had two distinct components.
Very interesting. Very
Next,
interesting. Possibly we all might have such kind of.
Yeah, these are the ones that are tough to swallow.
Yeah. It's true, man. It's true.
Okay.
So when we get such kind of cystic changes while aspirating from the salivary region, we should keep in mind that various lesions ranging from neoplastic to non-neoplastic, as Hannah has already said, it might present as a cystic lesion. So we need to look for the cellular components carefully, whether we're getting some oncocytes, and if we get some oncocytes and their arrangement, whether they are in sheets with honeycombing appearance or not. And we have to look for the mucocytes, epidermal cells, or intermediate cells if we are thinking of the mucoepidermal carcinoma, and that may low-grade mucoepidermal carcinoma can commonly present like this in these cystic changes only. And we also should look for the lymphocytes invading epithelial iron, because epithelial cyst also we might get, though it's not very much common. And last but not least, we should keep in mind that clinical radiological correlation is a must, because the ultrasound pictures or some CT findings, imaging findings helps us a lot to assess how the lesion can be. Can it be neoplastic or non-neoplastic? And if it is neoplastic, whether there is any chance of benign or malignant lesions by assessing the margins of the lesion and whether the lymph nodes are present or not. So we should keep in mind that also. So, ma'am, possibly you also have such kind of presentation with case and where radiology helped. Yeah.
Again, it could radiology again, unless there is a really good communication. Radiology, if you just depend on the radiology, it could be a problem. We had a male, a 55-year-old male referred from the Colliery Hospital with a history of pain and swelling over the parotid. And it later descended into weakness, difficulty in deglutition. The CT scan was done outside, and the report was left parotid abscess with adjoining cellulitis, invasion of left parapharyngeal space, and mass effect on pharynx. Then the patient was transferred to Kolkata and had an MRI done, which showed a left parotid mass extending medially into carotid space and parapharyngeal space with cervical lymphadenopathy.
Yeah.
So this was the ultrasound which was done by our radiologist, and you can see this lesion with cystic and solid components and neck nodes. So our sonologist did an FNSE from the salivary gland lesion and the patient independently again, it came to us for a plain and unguided FNAC of the neck node. Next. So this was what we got from the neck node. Degenerative background, atypical squamous cells. That's about all. So this could, since we, till we sort of found out, we ran around and found out about the parotid, this could easily have gone out just as a metastatic squamous cell carcinoma. But we got to know about the parotid, and this is what the parotid FNAC look like. Here you can make out the glandular component. Here are these cells, high-grade epithelial atypical cells with moderate eosinophilic cytoplasm. You can see the atypical squamous cells again. So this was signed out as a high-grade mucoepidermoid carcinoma because the predominant feature was these squamous cells, and it was signed out as such. So this was one case that I remember where it's important to, the sampling is important, clinical radiological correlation is important, proper history is important. Okay.
Excellent, ma'am. Excellent, ma'am. Thank you very much, ma'am, for sharing your experiences with us. So let's move on to our next case. Here we had a 30-year-old rural tribal lady from Tea Garden in North Bengal. She presented with a tiny swelling on the hard palate and noticed by her since 3 weeks only. And there was a history of tooth extraction. And the patient was habituated for chewing betel nut and occasional smoker because she was. On clinical examination, a submucosal tender lesion, this very sub-centimeter lesion was found on the left side of hard palate. Radio imaging was non-contributory. Clinically, the patient diagnosed as an inflammatory lesion or some minor salivary gland neoplasm. FNA was done, in which yielded a transparent mucoid aspirate. So let's look at the FNA smears. And these were the FNA pictures. Let me give the opportunity to invite sir, Dr. Vidyut Krishna Goswami sir. Can you please describe the smears, what we are seeing here?
Thank you,
what do you say?
Dear Shourav. Good evening, everyone. We are here in an excellent academic gathering. My heartfelt gratitude to the organizer, Professor Guha Mullik, and her team for this excellent academic piece and allow me to be here. So FNAC finding, you can see nicely that there are some squamoid cells with dense eosinophilic cytoplasm in monolayered sheets and in singles, many of them with mild nuclear enlargement, but not amounting to call them the dysplastic changes. Occasional large histiocytoid cells are also there. Good number of inflammatory cells in the mucoid smear background. No evidence of granuloma or epithelioid cells are seen. So these are the FNAC finding in nutshell.
Sure, sir. So if we sum up the FNA findings, there is squamoid cells with dense eosinophilic cytoplasm in sheets and also in single population. Many of them have mild nuclear enlargement, but this atypia is not amounting to dysplastic change. So, and there is also some occasional large histiocytoid cells, good number of inflammatory cells, many polymorphs in the background. No granuloma was there. So we're in dilemma. What it can be? We are finding some atypical squamous cells, and it might be possibility of a salivary gland lesion. So what can be the possibilities, sir?
So I think this is another very interesting slide. First of all, we are getting some squamoid looking cells, mucoid background. So naturally we think, and it is very recent onset. So we thought maybe a case of mucoepidermoid carcinoma because minor salivary gland is involved. Sometimes looking at the atypical squamous cells, you cannot rule out cystic degeneration in a case of squamous cell carcinoma, though there was no obvious growth. And last but not the least, the most important one is the benign squamous cystic lesions, squamous lined cystic lesions with some sorts of inflammation and regenerative atypia like that. So these were the basic three differentials what was in my mind looking at these slides.
Exactly, sir. we also thought of that, and the differential which we considered in this case was it might be mucoepidermoid carcinoma, or it might be squamous cell carcinoma, where the aspirate might not be totally representative of the lesion, or it might be some benign squamous cystic lesion only with a dense inflammatory background. So considering this background, we dispatched our FNAC report that there is presence of some atypical squamous cells in a mucoid background. We cannot rule out malignancy. So we asked for an urgent biopsy. So we got the biopsy slides also. In the biopsy, we are seeing that there is an ulceration of the surface epithelium with dense infiltration of the lymphocytes, plasma cell, and other chronic inflammatory cells in the acinous structures of the salivary gland. And the ducts are filled with mucin and dilated. And there is presence of metaplastic squamous epithelium lining the duct with assumption of squamous islets. So it's now pretty clear that we are dealing with a case of necrotizing myelometaplasia. So it was first described in the 1973. The age of presentation of myelometaplasia is most common in the fourth decade of life. The males are the predominantly affected. The pathogenesis is not been fully elucidated till now. The speculations are that it might be due to some inflammatory changes or some medical procedures, which is the metaplastic changes in salivary glands. And there are some associated factors have been seen. The heavy smoking, alcohol abuse, and upper respiratory infection might be associated with this lesion. And the most common site of the myelometaplasia are the posterior part of the hard palate. Okay, so
Saurabh,
yes, sir.
I just want to put some extra points in this because this is one interesting case. We thought that this is going to be a malignant one, but it came out ultimately one benign one. This myelometaplasia is really a very treacherous type of slides and presentation.
Yes, sir. I am only
yes,
just going to ask you this. So
yes,
can you please differentiate between the reactive and malignant? So it's a very difficult for us and from our PG days, and also our juniors are possibly might find very difficulty to assess. And so,
yes.
sir, please help me ask.
Before entering into your discussion of between that reactive mesothelial, reactive changes in the squamous cells and the malignant squamous cells, I just want to add few lines about this myelometaplasia. You know, this is very interesting. Carlson gave 5 characteristic histopathological features. Pseudoepitheliomatous hyperplasia to start with, squamous metaplasia of the ducts and acini, followed by preservation, but there will be preservation of lobular architecture. You know, this preservation of lobular architecture. In fact, few days back, I got one slide and there were the similar presentation, but that lobular architecture was not preserved. And ultimately that was signed out as, in the histopathology of course, not in the cytology. And ultimately it was signed out as mucoepidermoid carcinoma. So this lobular architecture is very, very vital while diagnosing any mucoepidermoid carcinoma, for at least for our part. And that will be followed by, usually there is lobular infarction and spillage of mucin. Ultimately there is inflammation due to that extravasation of the mucin. And obviously this necrotizing myelometaplasia, as I've already told, one treacherous diagnosis, misdiagnosed as mucoepidermoid carcinoma, histologically, mind it, squamous cell carcinoma, acidic cell carcinoma. Sometimes there may be some abnormal type of squamous hyperplasia leading to false diagnosis of verrucous carcinoma, even ductal carcinoma sometimes. But the beauty is that it is a totally benign condition and prognosis is excellent. Yes. So after adding all these things, now I am going to your how to differentiate between these reactive squamous cells and the malignant squamous. Yes. You know very well that this, in fact, the intention, if you think of that cystic change in the deposits of squamous cell carcinoma, it is a very, very common one, very important for our practice as well, and very difficult sometimes. And naturally, sometimes even we get some negative report, we write down, please do biopsy, particularly if the patient is aged, more than 40 like that. Now, why this diagnostic difficulty? Because you know very well that in these cystic changes, particularly in case of well-differentiated squamous cell carcinoma, there will be the squamous cells will be anucleate, they will be of parakeratotic type, there will be mature cytoplasm, small pycnotic nuclei. Naturally, cytologically, they will be very much bland looking. So how can you differentiate whether this is simple squamous line cyst or something like that? So this is a real big challenge to the cytologist. Moreover, if you think of one squamous line cyst, there may be sometimes that a secondary inflammation leading to regenerative atypia, degenerative changes, leading to appearance of some worrying cytological changes in the epithelial cell. So, and moreover, I also, in this scope, I want to draw one attention that in our regular PAP reporting, we are getting the same problem. In fact, I all the time I talk with my students and my colleagues that this PAP, why there are so many fragmentation, that LSIL, HSIL, ASCAS, AGAS, ASCAS-8, why? Because of the same thing that we want to classify them, whether we can make it a perfect diagnosis of regenerative or the malignant or neoplastic one.
It's a very difficult question to answer.
Very difficult, very difficult.
True.
So how can we get one clues? Already it is told several times in the past by all the probably all the speakers that clinico-radiological detailing. Always, I probably you can remember that in your student life, I always told that cytology is one science where pathologists become one great clinician. Okay, I think better clinician than the clinician, right? So clinico-radiological detailing, never forget to take this clinico-radiological detailing. Next, think that the cystic squamous cell carcinoma, they are more necrotic than inflammatory. More necrotic, I am just repeating. A careful search, you can, if you follow, then definitely, apart from these benign looking cells, definitely you can get some malignant squamous cell as well. And look for mitotic activity, including those atypical mitosis. And you know that what are those changes? They will be more hyperchromatic, there will be angulation, there will be BGR looking, globoid shape, the dense orangiophilic cytoplasm, abnormal keratinized cells. So all these features will definitely help us to draw one whether this is benign. Moreover, if you consider your reactive squamous cells, in fact, this can be also applied in any reactive or regenerative atypia, that there will be no hyperchromasia or little hyperchromasia, number one. Number two, NC ratio will be not altered. That will be there in case of your malignant cell. That nuclear membrane irregularity, that will not be there. And your nucleoli, that will be more prominent in case of your regenerative changes than in case of your
exactly, sir.
Even then, all applying all these things, you may not be possible. So one indeterminate or descriptive diagnosis you can give, but it should be there. You should give one explanatory note that clinical correlation is to be done and any persistent mass is to be excised to exclude malignancy. So this is about your reporting on your table. And if you think that regarding ancillary tests, yes, sometimes as because most of the squamous cell in the upper aerodigestive tract, they are related to your HPV infection. So likely that if you do one FNA sample PCR for HPV DNA, it may be positive. Or if you do one cell block study and IHC with surrogate marker like P16, it may be give something.
Yeah, indeed, sir. So actually, we have to stick to the basic in every time to differentiate from the malignant to benign cells, and there's very much importance of the background, whether we're dealing tumor diathesis are there or only polymorphs are there, and also the cytomorphological, the clinico-radiological correlation that gives a very usual clue. So whether it might be malignant or not. So what are the points we noted here? So Cyanobacteria is a spontaneous resolving inflammatory process. It can mimic a malignant tumor, especially in FNSC, and we always should keep a high element of suspicion while reporting these kinds of smears, and we can give much stress on the clinico-radiological correlation. So thank you, sir, for your valuable experience sharing. So let's move on to our next case. This is a case that is a very interesting one, and unusual finding was there. We got a 14-year-old female patient with a submandibular swelling for 1 year. Initial CT scan showed a pretty large tumor, 5 by 4 centimeter in the left submandibular region and extending to parapharyngeal region. It was previously excised in some other institute outside, but the tumor recurred. And now the CT scan showing there is very post-op case of submandibular gland with a bulky heterogeneous tumor with multiple ill-defined hypodense areas. So in the initial FNS smears, we got a cellular smear with many small round cells, which are mostly the dispersed population, and with occasional small microacinar patterns were there. The cells of scant cytoplasm, high NC ratio was there. And while going to the higher power, we can see that some cells show stippled chromatin pattern with no nucleoli. So considering this, we have done the cell block and do immunostains over it. And in that immunostain, we found that it was a cytoplasm positive, CD56 positive, pancreatic was scattered positivity, and chromogranin was negative. Ki67 index was around 20%. So we conclude the lesion as a giving diagnosis that it is a neoplasm with neuroendocrine differentiation. So after giving the diagnosis, the patient was shifted to Tata Medical Center, and I will request Dr. Indu, possibly you have the follow-up of this patient and the further workup, and ma'am, please share your experience regarding this case. Over to Dr. Indu.
The cytology slides of this patient was reviewed at our center and was reported in a similar manner. So the patient underwent parotidectomy, and here you can see the histology of the tumor. Here you can see a relatively well circumscribed tumor in the parotid gland, and which has a solid blue look in low power. Next slide. So this is a higher power view where you can see the cells have scanty cytoplasm and small hyperchromatic nuclei, and most of these cells are arranged in sheets with hemorrhage in between, and some of the cells showed this perivascular pattern, that is their peritheliomatous pattern, that is arrangement around blood vessels. Next slide. This is another view of the same tumor. Next slide. This is a higher power view where you can see that the cells have irregular nuclear membrane, stipple chromatin or powdery chromatin, and inconspicuous nucleoli, scanty cytoplasm. Mitotic figures were evident, but there were no areas of necrosis or crushing artifact. Next slide. So then we went ahead with immunohistochemistry. Next slide. So cytokeratin showed focal positivity similar to the cell block preparation, that is focal. Some of the cells also, previous slide, I have not finished with the, yeah. So there was some perinuclear dot-like positivity in some of the cells. Next slide. Next, yeah. So these cells also showed positivity for neuroendocrine markers like synaptophysin, CD56, and the expression was diffuse. Chromogranin showed focal patchy positivity, and Ki67 proliferation index was around 20 to 30%. Next slide. So the differentials we considered were, one was a small cell carcinoma because the tumor showed small blue tumor cells with dot-like perinuclear dot-like positivity for cytokeratin, and they were positive for neuroendocrine markers. But it lacked an increased mitotic activity or apoptosis or crushing artifacts, which are usually seen in a small cell carcinoma. Second differential was a neuroendocrine tumor grade 2, but it did not show any organoid pattern that is typical of a well-differentiated neuroendocrine tumor. Then the next differential was in Ewing sarcoma of salivary gland, which is very rare. Next slide. So we did CD99, which showed diffuse strong membranous positivity. Next slide. We went ahead with FISH for EWSR1 rearrangement, EWSR1 break apart FISH, which showed split signals. That is, you can see both red and green signals, which is suggestive of positivity for EWSR1 rearrangement. Next slide. So this was diagnosed as residual or recurrent Ewing sarcoma. Next slide. So a bit more about Ewing sarcoma. So this tumor was separately called as Ewing sarcoma. Both Ewing sarcoma and primitive neuroendocrine tumors were initially considered as separate entities. Now they are considered as a part of the same spectrum of disease, and in the current WHO on soft tissue tumors call this entity as only Ewing sarcoma. So this is very rare in the salivary gland, and only few cases have been reported, around 6 cases. And this is a prototype of small round blue cells. And immunohistochemically, they show positivity for neuroendocrine markers, and S100 positivity can be seen depending upon the degree of neuroectodermal differentiation. Strong membranous CD99 positivity is seen in around 95% of cases. And in the presence of both CD99 and NKX2.2 positivity, it is highly specific for the diagnosis of a Ewing sarcoma. And a FLY1 or ERG positivity can be seen depending upon the fusion partner. And the new entity which has been described in the head and neck region and also in salivary gland, parotid gland, is adamantinoma like Ewing sarcoma, which which shows diffuse positivity for cytokeratin and squamoid markers like P63 or P40, and can be confused as a poorly differentiated squamous cell carcinoma if CD99 is not included in the IHC panel. So at the molecular level, these tumors show about in 85 to 90% cases EWSR1 FLY1 fusion transcript, and in 5 to 10% cases EWSR1 ERG fusion, and rarely first ERG and first FEV translocation has also been described. Next slide. So most important differential diagnosis in this case is small cell carcinoma, because there is expression of neuroendocrine markers and cytokeratin dot-like positivity. It is a diagnostic pitfall if CD99 is not added in the panel. So the other round cell tumors which can show co-expression of CD99 and neuroendocrine markers, especially in a pediatric age group, are the following. That is, rhabdomyosarcoma can show CD99 expression and expression of neuroendocrine markers. So it is very important that we should include myogenic markers such as desmin, myogenin, and MyoD1 in the panel. Synovial sarcoma can also show CD99 expression and S100 positivity, and also CK expression. So TLE1 should also be included in the panel. Lymphoblastic lymphoma, very important. They can show diffuse membranous CD99 expression. So in the panel, it is very important that we should include CD45 and TDT. Sometimes lymphoblastic lymphomas can be CD45 negative. So TDT is essential. Neuroblastomas are positive for neuroendocrine markers, but CD99 is usually negative. Next slide. So the treatment and prognosis of these tumors, they are highly aggressive tumors. So a combined treatment approach, including surgery, irradiation, and chemotherapy, is a treatment of choice. And minimum follow-up data, there is very less follow-up data in literature on Ewing sarcoma in salivary gland. In general, prognosis is poor, with disease-free survival rate of approximately 50% in 3 years and 45% in 5 years. And there is propensity for distant metastasis to the lung, liver, and bone. Next. So our patient is on chemotherapy and interval radiotherapy. Over to you.
Thank you, ma'am. So it's indeed a very rare and very interesting case. And here we see that we have to take the help of very much ancillary techniques to come to a conclusive diagnosis. So, ma'am, whether there is any role of ancillary techniques on the cell block and which we can apply, which we can progress to the cytopathology, or like IC or fish.
Of course, there is a role of ancillary techniques. So all these ancillary techniques can be applied on cytology materials such as special histochemical stains such as musicarmine, Alcian blue, PAs with and without diastase. All this can be applied. Immunohistochemistry, fish fluorescent in situ hybridization, RT-PCR, next generation sequencing, flow cytometry, especially if you are suspecting a lymphoma. All these techniques can be applied on cytology material, such as it can be an alcohol fixed or air dried smears, cytospins, liquid based preparation, or formalin fixed paraffin embedded cell block material. So most of the time we make a formalin fixed paraffin embedded cell block material. This is more reliable. This is the most reliable method because for doing ancillary test, because it has been very much, it has been validated and have shown comparable results with when ancillary tests were done on the cell block material. They have shown comparable results with the biopsy material. And these tissues, cell block material can be stored and can be used for future use, especially for research purposes, or if you want to do additional immunohistochemistry, it can be done at a later stage. So in addition, salivary gland tumors, some of the salivary gland tumors can show specific gene rearrangement, which are diagnostic of these entities. But the absence of these gene rearrangement does not mean that that does not exclude these entities. Such as pleomorphic adenoma shows PLAG1 gene rearrangement, and sometimes they can also show HMGA2 rearrangement, and there is a PLAG1 antibody available. Mucoepidermoid carcinoma shows MAML2 gene rearrangement. Adenoid cystic carcinoma can show MIB and NF5B rearrangement, and a MIB antibody is available. Mammary analog secretory carcinoma shows ETV6 gene rearrangement. Hyalinizing clear cell carcinoma, which is now called as clear cell carcinoma, shows EWSR1 gene rearrangement. And cribriform adenocarcinoma of minor salivary gland or polymorphous adenocarcinoma shows PRKD gene rearrangement with multiple partners.
Excellent. Excellent. So let's come to the conclusion now. And so we have seen that by the help of the such varieties of ancillary techniques, and if we stick to the basic of our cytomorphology knowledge, we can go to some extent to the diagnosis of salivary gland lesions of this, considering these various morphological variations. So let me put a question. So how far can we depend upon the cytomorphology for different types of for this differentiating these various types of salivary gland tumors? And let me ask Professor Goswami, sir, what's your view regarding it? What do you, sir?
Yes, sure. Already we have completed one exhaustive discussion on pitfalls of FNAC in salivary gland lesion. And I have already told that here I just want to put some points in favor of cytology, because we are in cytology conference, right?
Yeah.
And this is very much proof that all the time, yes, core needle biopsy when it came, then if we go through the history even, then we will find that somehow cytology sometimes for years it was not being taken, though it was favorite in some other places, etc., etc. And after particularly, I can recollect very few years back, I had a talk with our most respected Pranavda, that I am talking in Bengali. Biddut, আমার গত 6 মাসে একটাও ব্রেস্টে কোনো সাইটোলজি হয়নি. We have no cytology in breast in last 6 months. So this was winning all these things. Now what is the picture? Particularly I can recollect Savitri Krishnamurthy's opinion and her excellent presentation. And now already Indu Madam also told that you can do so many things from the even the scraping of the smear. That is a beauty. That is you can do so many things from the cell block availed through the cytopathology. Okay, your techniques of cytopathology. So cytopathology is again revived. Cytopathology is in forefront in diagnosis, just like one phoenix bird, all the time it is going back, again it is coming forward. So definitely this is the beauty of this particular science. Thank you, Saurav. Thank you so
Indeed,
much.
sir. So it's definitely a very encouraging situation for Surya today. So over to Dr. Bhatia, ma'am. So what's your view regarding it? Ma'am?
I would also replicate Dr. Bidyut's views. But one thing is there, the advantage of cytopathology is that it's quick. And if it is malignant, then you can directly, it's quite satisfying at times. Though there is a lot of hair splitting and you may get somewhat diagnosis, which is not really. So with the Milan system coming in, especially salivary glands, if you see. So basically cytopathology would be, I would use it as a tool to guide the clinician as to the further management. If I'm not able to make a definitive diagnosis also, still I'm able to guide the clinician, and that's my primary role. So if we stick to that and we kind of try to help the clinicians, they'll start respecting our opinions as well. And fewer mistakes are also made. And if possible, then cell blocks, of course, can help us reach a definitive diagnosis. So yes, I feel it's both ways. It's not too hard to swallow, but swallow with caution. That's my statement. Yeah.
It's true. It's true that there's so much of pitfalls there, but we can progress with some of the entities and to such extent to help the clinicians.
Yes.
What do you, Shabas ma'am? What's your view regarding this topic? Over to Shabas.
Again, yes. Hello.
Yeah, ma'am.
Again, to agree with Dr. Bhatia, we need to look at, first of all, cytology helps a lot in screening between benign and malignant. It gives the clinician an idea. Secondly, we need to go in for ancillary techniques. Cell blocks, should be the rule rather than the exception. As far as possible, I would ask all the newer consultants, the newer pathologists to start practicing because we are doing cell blocks and staining on spheres. And I think everybody should practice and try to, because that helps us a lot. Again, it takes us to the next step of the differential. But then again, we cannot run away from histology being the gold standard. But you can give the clinician an idea, right?
Yeah, true, ma'am. We are also trying to practice cell block regularly so that we can give a better idea on the basis of the cytomorphology. And over to you, Indu ma'am. What's your opinion regarding this topic? How far we can depend upon the cytomorphology?
I would also agree with Sravasti ma'am, what she said. I would reiterate the same thing, what she had said now. Because here comes the importance of cell block preparation, because most of the time you cannot make a definitive diagnosis on cytology alone because of the overlapping morphologic features of many of the salivary gland tumors. So we should make it a practice that a cell block, a dedicated pass should be made to make a cell block, so that we can use it for the future for immunohistochemistry. Even if you don't have the facility to do immunohistochemistry, it can be sent to another center which has this facility, so that it can be better categorized for the classification as possible. And this will help in better patient management.
Exactly. So we are saying that if we stick to the basic, that how to differentiate the benign to malignant cells, and we keep an vigilance over the appearance of the smear, the cellular component, whether these are basaloid cells, oncocytic cells, or some leukocytes are there, epidermal cells are there, and also the stromal component, whether it's fibrillary or globular, and also keep in mind the various DDs what might happen in salivary gland pathology, and with the help of the ancillary techniques and all over the cell block preparation or stripping of the smears by applying immunostains over that, by applying the in situ hybridization over that, and we can definitely swallow the salivary gland cytomorphology. But we should keep a caution, and we should keep all the DDs in our mind while we are dealing with such kind of salivary gland conditions. So let's come to the end of this session, because thank you all the experts for sharing your views and your experience with us. And so let's conclude the session. Thank you all. Over to
Thank you so much, Dr. Bhomik.
Thank you so much.
Thank you, all the panelists. Dr.
Thank-
Bhomik, if I may please request you to briefly just go through a few of the comments in the chat box. Oshitabu sir has also written something, and plenty of comments, I guess. If you could just read out a few. Just briefly.
I will get that from the chat box, possibly.
Yes, please, if you could.
Dr. Nadeem has written that the bar of presentation, along with its contents, has been raised to an international level. All credits to the speakers and managers. Well done, Wisdom Satellite Society.
Mamata ma'am, I guess, had a few questions, but I'm sorry we do not
Possibly-
have
possibly-
much time about that.
Possibly, I am not seeing all of them.
Okay,
If you
I'll
can
just try
see,
out
please.
over here. I'll
Yeah.
just try out. Yes, I'll just try out here. Dr. Ashitabu Mondol had actually written about case 5, I think, that there were rosette-like structures in the FNAC. So that was one comment that I wanted to read out. And
Yeah,
Dr.
I have
Malik
mentioned that there is my
Okay.
question has some patterns are there, and with
Okay.
the codes granular chromatin, we thought about the neuroendocrine differentiation might be there. That's why we have put the immunomarkers of the neuroendocrine panel, and we got this synaptophysin positivity, we got this positivity, and we discussed a case as a neoplasm with neuroendocrine differentiation.
Right. Thank you so much. I hope sir has heard that from us. And Dr. Malik very kindly has stated that he stayed back for this presentation, all of them actually. And that was so kind of him. And yes, I guess lots of comments which have read that excellent discussions, and the panelists were excellent. The doubts, I think, if you could please type out the questions in the chat box, which are already there for that matter. If the speakers could be kind enough, the esteemed speakers, the panelists, if you could please type out the responses in the chat box later. I think that would serve the purpose. We are running a little late now, so I think I should thank you for, again, Dr. Bhomik, for a wonderful panel discussion. That was really splendid. With that, we come to the end of the first day of our program. I would like to thank the organizers, the sponsors, speakers, and delegates for making this day a memorable one. A special thank you to Gaurav and Deepak for holding our hands every step of the way on this digital platform. We hope to see you all tomorrow at 9 a.m. for the 14th Annual State Cytology Conference 2021, organized by West Bengal Cytology Society. Good night all. Stay safe.